We are live.
Good evening, everyone. Welcome to the fourth episode of AIOS GuruSangam. Today's session is about conjunctiva. I would like to thank our AIOS dignitaries, Dr. Partha Biswas sir, President AIOS, Dr. Santosh Unawar sir, Honorary General Secretary AIOS, Dr. Manoj Chandra Mathur sir, Honorary Treasury AIOS, for this wonderful concept and curating this session so precisely. Speakers for today's session are Dr. Archana Vare ma'am from Government Medical College Aurangabad, Dr. Supriya Mushrif ma'am from Index Medical College Indore, Dr. Mallikarjun M. Hiralagi sir from Shankara Eye Hospital Shivamoga, Dr. Chandana Chakravarti ma'am from Bankura Samimilani Medical College, and Dr. Madhuri Parande ma'am from Mysore Medical College. The expert panel consists of Dr. Sharmila Devi Vadivalu ma'am from Vellore Medical College, Dr. Shweta Agarwal ma'am from Shankara Nethralaya Chennai, Dr. Tuhin Chaudhary sir from Disha Eye Hospital Kolkata, Dr. Vanathi ma'am from RP Center for Ophthalmic Sciences New Delhi, and Dr. Varun Malhotra sir from Center for Sight Hyderabad. So the topic for today's session are embryology of the eye and congenital anomalies, anatomy and diseases of conjunctiva, common signs in cornea and their clinical implications, approach to a case of conjunctival lesions, and recent advances in surgical management of pterygium. I, Dr. Lipi Mittal from Center for Sight Palwal, along with Dr. Gunjan Budhiraja from I7 Eye Hospital, New Delhi, will be moderating this session. And I thank Rolika ma'am for giving us this opportunity. So without any further ado, I would like to invite our first speaker, Dr. Archana Vare ma'am. She will be speaking on embryology and congenital anomalies. Over to you, ma'am.
Yeah, good evening. And at the outset, I would like to thank the AIOS and Guru Sangam for giving me this opportunity. And I'll just share my screen. So is my screen visible?
Yes, ma'am.
And am I audible also?
Yes, ma'am.
Okay, thank you so much. So today I'll be speaking about the embryology and congenital anomalies of the eye. And this is a very, very important topic for the postgraduates. There's no financial interest, and content of this presentation has been taken from multiple online sources strictly for academic purposes. So what is embryology? So embryology is the study of development of an embryo from fertilization to the fetal stage. So this is the fertilization stage, and this is the fetal stage. What is an embryo? So developing human during the early stages of development is called as the embryo. Then this is the cranial end of the embryo, and this is the caudal end of the embryo. This is the ventral surface of the embryo, and this is the dorsal surface of the embryo. So when does the eye develop? So the development of the eye starts from 22 days of embryonic life, when the length of the embryo is 2 millimeters and the embryo is in 8 somite stage. So why do we want to learn about embryology? So as an ophthalmologist, having a solid foundation in ocular embryology can prove critical for recognizing and managing congenital eye disorders. So the early embryonic development of the eye begins with a process called as gastrulation. So this is the picture showing early embryonic development, but due to lack of time, I won't be going in details. But this is day 1 of fertilization. Then this is day 2 of cleavage. Then next is day 3 compaction and day 4 differentiation. Then on day 5, there is cavitation, and the zona hatching occurs on day 6. Then this is the human embryo that is on day 9, and the development of the eye begins with the process called as gastrulation. So this is blastocele, this is the blastula, and this is the gastrula. Now, what do you mean by gastrula? So gastrula is that term, that phase of embryonic development where all the 3 germ layers, that is the ectoderm, mesoderm, and endoderm, they are present. So by 3rd week of development, the 3 germ layers are arranged in a flat disc-like structure called as the trilaminar disc. So this is the trilaminar disc, and it consists of the ectoderm, the endoderm, and the mesoderm. Then development of the eye, basically it occurs from ectoderm and the mesodermally derived mesenchyme. And this ectoderm is of 2 types, the neural ectoderm or the neuroectoderm and the surface ectoderm. So this is the trilaminar disc that I was talking about. And this trilaminar disc has ectoderm, endoderm, and mesoderm, but I have not shown the mesoderm here. Then this is the cranial end of the embryo, and this is the caudal end of the embryo. This is the ectoderm, and this is the endoderm. Then an oropharyngeal membrane, it develops at the cranial end of the embryo, which forms the future mouth, and a cloacal membrane forms at the caudal end of the embryo, which forms the anal canal. Then this is the ventral view, and you can see this is the notochord. Now, this notochord, which forms the future spinal cord, is very important for development of the human eye. And this is the oropharyngeal membrane, and this is the notochord. Okay, so this notochord, what it does, it's releases some signaling molecules. Now, this is the ectoderm. Now, this ectoderm, because of the signaling molecules released by the notochord, it shows thickening in the central part. And this is nothing but the neuroectoderm. So, this thickening, this flat layer of the thickened neuroectodermal cells is called as the neural plate. So, neural plate is nothing but the thick neuroectodermal cells. So, this is from the top view. And then at the cranial end of the neural plate, there is formation of the eye field. So there are some cells in the cranial end which develop the eye field. And this is under the PAX6 protein. And this protein is also called as the master regulator of the eye movement. So this eye field, initially it is a single eye field, but then later there is a protein which is called as sonic hedgehog protein. So this sonic hedgehog protein released by the precaudal plate, it divides the single eye field into two separate eye fields. Then this is the division of the single eye field. And if this division does not occur, then there is a clinical condition which is called as cyclopia, which is very rare, and wherein there are no two eyes, but only single eye is present in the center. Okay, now let us see what is nerulation. So we have seen what is during nerulation, what happens is a neural plate folds on itself to form the neural tube. So we have seen the formation of the neural plate. Now this neural plate, it folds on itself and it forms the neural tube. So this is the neural plate, and you can see these arrows. So this neural plate, it folds in the direction of the arrows and it forms the neural tube. So these neural folds, they come in the center and they meet at the center, they fuse in the center, and there is formation of the neural tube. Now let's see this video. So this is the neural plate. This neural plate, it undergoes invagination. It forms the neural folds, and these neural folds, they meet in the center and forms the neural tube. This neural tube is fused in the center, but it is open at the anterior part, which is called as the anterior neuropore, and also at the posterior part, which is called as the posterior neuropore. So fusion of the neural folds occurs in the center, and the optic grooves are present on each side of these neural folds. So this is formation of the optic grooves or the optic sulcus. So this is the lateral view showing the optic grooves, and this is how the optic groove looks like. Now, after the formation of the optic groove, there is folding of the embryo. Now we can see this is a neural tube and this is the gastrointestinal tube. From this neural tube, the future brain is going to develop. Okay, and as there is folding, then there is formation of the prosencephalon, which is the future forebrain, mesencephalon, which is the midbrain, and rhombencephalon, which is the hindbrain. So this prosencephalon, again, it develops into the telencephalon and the diencephalon. And the optic grooves are present on the diencephalon. So it is very important to know that the optic grooves are present on the diencephalon. So let us see this video now. So this video shows the folding of the embryo, and then there is formation of this diencephalon, and this is the telencephalon. So then this is the midbrain and this is the hindbrain. So this diencephalon, it shows the formation of this optic sulcus. And then this optic sulcus, it grows laterally and it forms the optic stalk. So let us see how. So this is the optic groove. This optic groove, it grows laterally and it forms the optic vesicle. So this is how the optic vesicle is formed from the optic pit. Okay, so now let us see this line diagram. So this is the cavity of the forebrain, and this is the optic sulcus. Now this optic sulcus, it undergoes invagination, and then there is lengthening of this optic sulcus, and the proximal part, which is called as the optic stalk, and the distal part, which is globular, is called as the optic vesicle. Okay. Then now this is the optic vesicle, and the proximal part, it elongates and it forms the optic stalk, and the distal part is globular and it forms the optic vesicle. Now there is development of the hyaloid artery. So this hyaloid artery develops to give nourishment to the developing embryo or developing eye. So this hyaloid artery is just present beneath the optic vesicle and the optic stalk, and they undergo invagination to accommodate this hyaloid vessel. Okay, so and when they accommodate this hyaloid vessel, then there is formation of the choroid or the optic or the embryonic fissure. Okay, so let's see this video. So this is the hyaloid artery. So this hyaloid artery, it goes into the optic sulcus and the optic stalk, and there is formation of the choroidal fissure. So this choroidal fissure is formed to accommodate this hyaloid vessel. So now this after accommodating the hyaloid vessel, there is closure of the choroid fissure, which occurs on the 33rd day of the intrauterine life. If it doesn't happen, then there is formation of the colobomas. So this is how the closure of the choroidal fissure looks like. And after formation of the choroidal fissure, there is formation of the two-layered optic cup. So we have seen that there is formation of the optic stalk and the optic vesicle. And after formation of the choroid fissure, the optic stalk or the optic vesicle is converted into the optic cup. Now let us see how the lens develop. So the lens develops from the surface ectoderm. So this is the optic vesicle and this is the lens placode. Now this is the surface ectoderm, and this optic vesicle, it comes from the neuroectoderm. So they are always in contact with each other, the neuroectoderm and the surface ectoderm. The part of the surface ectoderm, which is destined to form the lens, it shows thickening, and this part is called as the lens placode. Then it shows invagination and it becomes the lens pit. And at the same time, this optic vesicle is also undergoing invagination and it is forming the optic cup. And then there is formation of the lens vesicle, and this lens vesicle is pinched off from the surface ectoderm, and the surface ectoderm, again, it regularizes. So let us see some videos for this. So first is the optic vesicle and ectoderm, which are in contact with each other. And this is the lens or the optic placode. Then this is the lens pit, and this is the hyaloid artery. So everything is going on simultaneously. The formation of the choroid fissure, formation of the optic cup, and formation of the lens vesicle, everything is going on simultaneously. So this is how there is formation of the lens pit. And the lens pit is it gets sucked into the lens vesicle, and the surface ectoderm continues. So let us see a video. So there is pinching of the lens pit. So here you can see the lens pit, and it gets pinched off from the surface ectoderm, and it goes into the optic vesicle. And then there is pinching off, and it accommodates the hyaloid artery as well. Okay, so this is the lateral view. This is the optic vesicle and the ectoderm. This is the hyaloid artery. And now here you can see the formation of the two-layered optic cup. So the optic cup is formed after the formation of the choroidal fissure. And then this is the lateral view showing the hyaloid artery, which supplies the developing lens vesicle. Now, this hyaloid artery, then it turns into the tunica vasculosa lentis, which is nothing but a capillary network, and it supplies the superior, inferior, and the posterior aspect of the lens, but it is deficient anteriorly. So this, see this video, and you can see the formation of the hyaloid artery and the tunica vasculosa. Okay, so this shows the formation of the tunica vasculosa lentis. I don't know this video. It's not moving. Okay, so there's formation of the tunica vasculosa lentis. Yeah, see. So it is present on the superior, inferior, and the posterior aspect, but it is absent anteriorly. So this is the formation of the optic cup. Now let's see formation of the lens fibers. So this is the posterior lens epithelium and this is the anterior lens epithelium, and this epithelium, it secretes the lens capsule. So this is the lens epithelium, anterior and posterior, and it secretes the lens capsule. Okay, now this posterior epithelium, it loses its nuclei, and once it loses its nuclei, these cells, they elongate and they are called as the lens fibers. Okay, so we'll see this video. Okay, so this is how the lens fibers are formed. Then the lens fibers are always, the formation always starts at the equator and they go towards the periphery. So newly formed lens fibers are always seen at the periphery, and the old fibers, they go towards the center, forming the lens nucleus. So this is the lens nucleus which is formed in the center, and this is the cortex of the lens which is present at the periphery. So this is the arrangement of lens nucleus and cortex. In the center, we have the embryonic nucleus, which is surrounded by the fetal nucleus, then which is surrounded by the adult nucleus. Towards the periphery, we have the cortex, and then there is an epithelium and the capsule. Now, these lens fibers are held together with the help of Y sutures. An erect Y is present on the anterior surface and an inverted Y is present on the posterior surface. Now, let us see development of iris, cornea, and the anterior chamber. Now, we have seen that this is the neuroectoderm. This is the double-layered neuroectoderm, which forms the optic cup. So, the inner layer of the neuroectoderm forms the neurosensory retina, and the outer layer forms the pigment retina, and there is always an intraretinal space in between them. Now, this is the lens vesicle, and this is the surface ectoderm. Now, what happens here is the margin of the optic curve, it grows towards, both the margin, the superior and the inferior, they grow toward each other and they form the primordium of the iris. Okay, so this is how the primordium of the iris, it is formed, but it leaves behind the central space to form the pupil. And then there is mesodermally derived mesenchyme. This mesenchyme plays a very, very important role. Now, this mesenchyme, as we can see in green color, it is present there. And then there are small spaces which appear in this mesenchyme, and then these coalesce to form the anterior chamber of the eye. So this is how the anterior chamber of the eye is formed. These small spaces appear and they coalesce to form the anterior chamber. Now we have some mesenchyme which is present anterior to the anterior chamber, and there is some mesenchyme which is present posterior to the anterior chamber. Now, what is the fate of this mesenchyme? So the mesenchyme which is present anterior to the anterior chamber, along with the surface ectoderm, it forms the cornea. And the mesenchyme which is posterior to the anterior chamber, along with the neuroectoderm, it forms the iris. Okay, now let us see first the formation of the cornea. First, we will see the formation of the corneal endothelium. So there are neural crest cells which are present in this mesenchyme, and they are supposed to originate from the neuroectoderm actually. So these neural crest cells, they grow in the space in between the anterior chamber and the surface ectoderm, and they are haphazardly arranged. They are not arranged in a proper endothelial manner. Because these cells, they are loose and they don't have any intercellular connections. But then these cells, they undergo mesenchymal to epithelial transition, and then a properly arranged epithelium or the endothelium is formed, and with tight intracellular junctions. So this is how the haphazardly arranged endothelium is here initially, and then it undergoes mesenchymal to epithelial transition, and then there is formation of the corneal endothelium. So let us see, there are neural crest cells here, and these neural crest cells, they grow towards each other and they form the haphazard endothelium, and then it undergoes transition, and there is formation of the corneal endothelium. Then the endothelial cells, some say that they are from neural crest, some say they are from mesenchyme. So now let us see the development of the primary corneal stroma. So we have seen the endothelium development. Now this surface ectoderm, which is cuboidal to columnar, it undergoes proliferation and it becomes stratified squamous epithelium. And it secretes the primary corneal stroma, which is acellular. So this is the proliferation of the epithelium, and this is the stroma, which is acellular initially. So this is primary stroma. Then The neural crest cells, they grow in the primary stroma and it forms the secondary corneal stroma. So this is how the secondary corneal stroma is formed, and the endothelium, it secretes the Descemet's membrane, and the epithelium of the cornea, it secretes the Bowman's membrane. Okay, so this is how the endothelium and the epithelium, they secreted Descemet's and the endothelium, Bowman's membrane. So these are the 5 layers of the cornea, starting from the epithelium, the Bowman's membrane, the stroma, the Descemet's membrane, and the endothelium. And this corneal stroma is the fibers, they are very, very well arranged so that to maintain the corneal transparency. So this is the summary of development of cornea, but due to lack of time, I'm not going in details. Then the development of the choroid and sclera, they are derived from the mesenchyme. And the choroid continues anteriorly with the iris, and the sclera continues anteriorly with the cornea. And this sclera, they both of them develop from the mesenchyme. Sclera continues with cornea. It is analogous to dura mater. And this one is, the choroid is analogous to the pia and arachnoid matter. So there is an iridopupillary membrane which is present here and which disintegrates just before the birth. Then let us see development of the iris muscles. They are very unique in their development, and this is the iris now. So the primordium of the iris, it forms the dilator pupillae and the sphincter pupillae muscles. So this is the dilator pupillae muscle, this is the sphincter pupillae muscle, and they are the only muscles which are developed from neuroectoderm and they are not derived from the mesenchyme. This is the development, summary of development of the iris. Again, we are not going in details. Now, this is the hyaloid artery and this is the tunica vasculosa lentis, but just before birth, it undergoes disintegration. And the proximal part of this artery, it forms the central retinal artery. So this is the hyaloid artery and tunica vasculosa lentis, which undergo degeneration. Now, coming to the development of the ciliary body. So this is the double-layered retina with the space in between, that is the intraretinal space. So the ciliary body develops in between the space between the retina and the iris. So let us see how. Okay. So the proliferation of the cells from the double-layered epithelium and the choroid, they are responsible for development of the ciliary body. So here you can see there is proliferation and they undergo invagination, and the mesenchyme, it also helps to develop the ciliary body. And the zonular fibers and the ciliary muscle, they develop from the mesenchyme. And the ciliary muscle is always attached to this scleral spur at the iridocorneal angle. This is again the summary of the development of the ciliary body. Now coming to the vitreous. So there is primary, secondary, and tertiary vitreous, and it is formed from the mesenchyme. So this is the vitreous body secreted by the mesenchyme. This is the hyaloid artery, and which undergoes disintegration, and there is formation of the hyaloid or the Cloquet's canal. Coming to the development of the retina, so we have seen that this is a two-layered layer, and there is now there is obliteration of the intraretinal space, but this potential space always it is present throughout life, and it may give rise to retinal detachment, which is the separation of the RPE, that is retinal pigment epithelium, from the neurosensory retina. Now, this blue color structure develops into the RPE, and the neurosensory retina develops from the inner layer of the optic curve. Okay, so this pars optica retini is responsible for formation of the retina. Then there is pars ceca retini, which is responsible for formation of ciliary body in the iris. The pars ciliaris retini develops into ciliary body, and the pars iridi retini develops into the iris. Now, this is the ora serrata, which is the anterior termination of the neurosensory retina. And see how the ora serrata is formed. So this is the ora serrata, and this is the 3D model which shows the formation of the ora serrata. Then let us see formation of the neurosensory retina. So this is how it is formed through the inner layer of the optic cup. So this is the retinal pigment epithelium, which forms from the outer layer of the cup, and then there is formation of the photoreceptors. So these are the cones, and these are the rod photoreceptors which are formed, and then there is formation of the bipolar cells here. So this is how the bipolar cells are formed, and then there is formation of the ganglion cells, and these ganglion cells then they form the nerve fiber layer, or the axon. These are the axons of the bipolar cells. So formation of the optic nerve. So it is formed from the optic nerve is nothing but the all the nerve fiber layers from the ganglion cells, and it forms in the region of the optic stalk. And these cells from the optic stalk, they form the axons or the oligodendrocyte to support it. Okay, the optic nerve is nothing but a white matter tract, and it is covered by the arachnoid and pia, which continues as choroid, and the dura mater, which continues as the sclera. Then development of the eyelid, it starts during the 5th week, and the eyelid remains closed until the 26th to 28th week. So this is how the surface ectoderm proliferates, and with the help of mesenchyme, it forms the eyelid. So this is the ectoderm, and it proliferates, and with the help of mesenchyme, it forms the eyelid. So this is the skin of the eyelid. The skin, cilia, and the glands, they also form from the ectoderm, and the tarsal plate and orbicularis oculi muscle, they form from the mesenchyme. And the conjunctiva, it has two layers: the stratified squamous epithelium, which forms from the ectoderm, and substantia propria, which forms from the neuroectoderm. The mesenchyme. Then there is development of the lacrimal gland. So it begins in the 7th week of gestation, and it forms from the neural crest cells. Now let us quickly see the important congenital anomalies, because it is not possible to cover everything in 30 minutes. So this is anophthalmia, where there is absence of the ocular tissues in the eye socket. Then this is microphthalmia. It is defined as the condition wherein the total axial length of the eye is less than the standard for the patient, that is less than 16 millimeters at birth. Cryptophthalmos or hidden eye is a rare congenital condition where the eyelids are absent. Then congenital anomalies of the eyelid coloboma is thought to be a form of facial defect. It is not because of the choroid fissure. Then congenital ptosis is associated with weakness of the LPS muscle. Then there is blepharophimosis syndrome, which causes blepharophimosis, ptosis, epicanthus inversus, and telecanthus. Telecanthus is uncommon palpable anomaly where there is increased distance between the two medial canthi. Then congenital dysgenesis, where extra row of eyelashes is present, and it replaces the orifices of the meibomian glands. Then we have congenital entropion, which is a malposition of the eyelid causing an abnormal inversion of the eyelid margin. Then let us see congenital anomalies of the cornea, wherein we have the microcornea, where the horizontal diameter of the cornea is less than 10 millimeters. Then megalocornea, where the horizontal diameter of the cornea is more than 13 millimeters. Then cornea plana, it's a congenital condition where the cornea is flattened and the angle between it and the sclera is decreased. Then congenital anomalies of the uveal tract. So we have the iris coloboma, and we also can have the coloboma of the ciliary body and the choroid, and it may be of the optic nerve as well. So this is because of the failure of the closure of the embryonic or the choroidal fissure. Then we have aniridia, which is a rare genetic disorder in which there is variable degree of hypoplasia or absence of the iris. Then polychoria, which shows more than one pupil within existence of more than one pupil within the iris. And correctopia is nothing but the displaced or ectopic or irregular pupil. It is formed by the irregular neural crest cell migration. Then persistent pupillary membrane, we saw the development of the iridopupillary membrane, which is actually it should disappear before birth, but sometimes it persists, forming the persistent pupillary membrane. Then there is Bergmester's papilla, which is nothing but the remnant of the fibrous sheath surrounding the fetal hyaloid artery. And this is how it looks on the OCT. Then let's see congenital anomalies of the lens. So we saw the Y sutures. So there may be formation of the sutural cataract, or there may be an anterior lenticonus where there is conical protrusion of the lenticular capsule, and anterior and the posterior lenticonus, which are seen in the Alport syndrome and the Loess syndrome respectively. Then we have lentiglobus, which is a rare congenital anomaly showing a prominent spheroid elevation on the posterior surface of the lens. Then we have lens coloboma. It is due to defective or absent development of the zonules in any segment. It is actually a misnomer. This is because of the absence of zonules. So then microspirophakia, it is characterized by increased anteroposterior diameter and reduced equatorial diameter of the crystalline lens. And the last segment is congenital anomalies of the optic disc, where we see the optic nerve hypoplasia, which consists of the tetrad of small optic disc, peripapillary double ring sign, thinning of the nerve fiber layer, and vascular tortuosity. Then we have the morning glory disc anomaly, where there is an enlarged excavation and abnormal retinal vascular pattern of the optic nerve. And this is the optic disc coloboma. And this is megalopapilla, which is an anomaly that consists of an enlarged optic disc with normal disc morphology. Then we have an optic pit, which is an excavation of the regional depression of the optic nerve head. And then we have myelinated nerve fibers. These are seen anterior to the lamina cribrosa. They have a myelin sheath. And last segment, congenital anomalies of the vitreous, where we can have the persistent hyperplastic primary vitreous, which is seen in 95% in premature infants and 3% of normal full-term infants. This fetal vasculature persists and can result in spectrum of disorder. Then this is persistent hyaloid artery, and this is the Mittendorf dot, which is present on the posterior lens capsule. So these are my references, and I thank you for this opportunity. And this is my lovely department where I work. So thank you so much for your patient hearing.
Thank you so much, ma'am, for simplifying embryology so beautifully. May I request Dr. Sharmila ma'am for her inputs?
That was a very complex topic, well covered, ma'am. Actually, those videos and animation pictures were very useful. I think it'll be a ready reckoner for the residents who are applying for who are appearing for exams. I think the applied anatomy is very, very important, and basically, like Madam demonstrated all that invagination and what are the structures derived from the surface ectoderm and the neuroectoderm. So that is very important, and the applied anatomy, I think she covered every part. So I think the most frequent questions are, the hyaloid artery remnants, Mittendorf dot, the Buckminster papillae. Even she showed even the OCT picture of it, and aniridia, like what happens when the PAX16 is defective, and what exactly happens. And I think the first few slides showed how the PAX16 deficiency can cause, and I think Madam covered everything. So these are the key points that the lens placard and the lens vesicle, how it develops and all that, and the Y cataract, the anterior, the posterior. So all these are questions which can be asked frequently in the exams.
Thank you, ma'am. I think it took me back to my residency days. It is a very important topic
Yeah.
for the residents. May I now request Dr. Varun sir for his inputs? Sir, you're muted.
Sorry, I'm so sorry. I think it was a great talk. To be very honest, I think it's extremely important to understand the anatomy, because once you get into clinical practice, you'll realize that how you are able to. I mean, it's very important to understand this to be able to apply these concepts into your, clinical practice, and how do you basically synergize this to treat patients. And I think there's not much for me to ask or say, frankly, here. I would just like to applaud her presentation. That's about it.
Thank you, thank you. And it is a difficult task to present everything in
Yes.
30 minutes.
Yes.
Absolutely.
You covered it beautifully, ma'am.
Thank you so much, ma'am.
Thank you. Thank you, sir. So we'll move on to our next speaker, Dr. Supriya Mushrif, ma'am. She is going to present anatomy and diseases of conjunctiva. Over to you, ma'am.
Thank you, everyone. Thank you, AIS, for giving me this opportunity for anatomy and disease of conjunctiva. So I'm starting to share my slides. Excuse me. I hope I am visible. Hello.
Yes, ma'am. Can you make it full screen slideshow mode?
Can you see the screen? I have
Yes,
shared
ma'am.
my screen.
The screen is visible. Can you make it full screen?
Wait. स्लाइड शो में करना पड़ेगा। अच्छा, यहाँ से I hope the slides are visible.
The slide is visible, ma'am, but can you make it full screen? Sunil ji, can you help, ma'am?
Yes, excuse me.
Ma'am, can you put it on slideshow mode
Yeah,
from upside?
wait, wait, okay. Wait. This is slide show.
नहीं, इस पे नहीं हो रहा।
Huh?
तुम चाहे शेयर कर इसके बाद ये ज़्यादा
I don't know. Am I? Is now? Is it
We
okay?
can see your screen. Can you make it from the slideshow, which we can see above, where you have seen home, insert, design, animations? There's a slideshow up.
Yeah, yeah. I know. There is slideshow. Yeah.
Yeah, can you? Yeah, yes. Thank
Is
you.
that okay now? Is it okay? I have done whatever you have told
Yeah,
me.
please click again, ma'am, from the beginning. This one, icon you clicked. Yes.
From beginning, right?
Yeah, please.
Is that okay?
Please. Okay. Can you, ma'am, reshare, stop and reshare again?
Sure. Is that okay?
Yes, very well. Yes, we can see it.
So thank you everyone, AIS, for giving me this opportunity. I'm Dr. Supriya Mushrif and I will be presenting anatomy.
Doctor, can you click on the screen first and then roll the slide? Just click on the screen and then move the slide. Yes, it's moving now.
It's moving, but I don't know why upper slide is not going down.
Ma'am, we are on the learning objective slide. If you want to move
But,
further,
that line is from here I can't see. इसको ऊपर का हटाना है.
you can stop and reshare if you want. Can you just stop and reshare if you want?
Sure. I will. Stop share. ये नहीं जा रहा है. Can you see? ये चीज ऊपर, हाँ, ये ऊपर की चीज.
Can see, ma'am.
I just want to remove that layout which is coming with. I can't see my slides now. Just like that. How can I remove the above layout?
There is minimize button, like a horizontal line. You can click on that line and it will disappear. Can you see that horizontal small line? The first thing.
Ma'am, we can see the slide. What are the problems you're facing?
She doesn't want that window. She doesn't want that window.
It window is again in there.
See her slides.
So to start with, thank you. So I think now I'm comfortable. I hope you all can see.
Yeah,
Sorry for the disturbed start. So to start with anatomy and disease of conjunctiva, I'm Dr. Supriya Mushrif. So to start with conjunctiva, it is a thin transparent mucous membrane, which and the word conjunctiva is the word conjunctiva is taken from Latin word conjoin. So what does it mean? Conjoin. It is to join. So our conjunctiva joins two things: the eyeball and the eyelid. Hence the word conjunctiva is there. So there are different parts of conjunctiva: palpebral conjunctiva, bulbar conjunctiva, and fornical conjunctiva. So this is the diagrammatic presentation of how the conjunctiva. This is the palpebral conjunctiva, this is the bulbar conjunctiva, and the junction is fornical conjunctiva. Parts of palpebral conjunctiva is again marginal, tarsal, and orbital conjunctiva, which covers the respective areas. Bulbar conjunctiva, which covers the sclera, has two parts, which covers sclera and limbus, which now the fornical conjunctiva, which is the junction of bulbar and palpebral conjunctiva. And the applied anatomy, which is important for this fornical conjunctiva, is ducts of the lacrimal gland open into the lateral part of the superior fornix. Now, there are three layers in the conjunctiva: epithelium, adenoid, and innermost fibrous layer. So the epithelium has variation in various different parts of the conjunctiva. In marginal, it is 5-layer non-keratinized stratified squamous epithelium. In dorsal and orbital, it is 2-layered stratified cuboidal epithelium. Fornical and scleral is having 3-layered stratified squamous epithelium, and limbal it is having 10-layered stratified squamous epithelium. Now the cells present in epithelium are goblet cells, melanocytes, Langerhans cells, CL malt, and now the adenoid layer. Now the adenoid layer is mostly made up of lymphoid layer, and the importance of this layer is it produces follicular reaction in various conjunctivitis, but it is not present in birds. So it develops after 2 to 3 months of the life. So during conjunctivitis and during this 2-3 months of the early life, it doesn't produce any follicular reaction. Fibrous layers of the conjunctiva is mostly made up of collagenous fiber and elastic fiber. Now, conjunctival glands are mostly mucinous gland which secrete mucin, are goblet cell, Henle cell, and glands of Mann, and the accessory lacrimal gland of Ross and Wolfram. So these mucinous glands secrete mucin, which forms the mucinous layer of our tear film, and the accessory lacrimal gland secrete aqueous layer of our tear film. So this is the various distribution of the various glands present in our conjunctiva. Now the blood supply of the conjunctiva is mostly by the anterior ciliary arteries, peripheral tarsal arcade. This is how the blood supply looks. Now the venous drainage, veins from the conjunctiva drain into the venous plexus of the eyelids and some around the cornea into the anterior ciliary veins. So this is a detailed diagrammatic representation, but can't describe it because of lack of time. Now this is the most important thing, lymphatic drainage of the conjunctiva. Now why it is important? Because in conjunctivitis, this lymph nodes get enlarged. So the medial part of our conjunctiva mostly drains in the submandibular lymph nodes, and the lateral part of our conjunctiva drains into superficial parotid lymph node, and ultimately both of them drain into deep cervical lymph nodes. So during conjunctivitis, during diagnosis, sometimes we should palpate this preauricular and submandibular lymph node and helps in diagnosis. And also during follow-up, we can see the regression of this lymph node and helps in the prognosis of our treatment and management of the conjunctivitis. Nerve supply is mostly from the 5th nerve. Now the diseases of conjunctiva. There are various diseases of conjunctiva. Of it is most common is subconjunctival hemorrhage, inflammation of conjunctiva, infection of conjunctiva, which is known as conjunctivitis, and degeneration of the conjunctiva. So to start with subconjunctival hemorrhage, most common subconjunctival hemorrhage is due to conjunctivitis, and sometimes it is mostly due to systemic diseases like uncontrolled hypertension, diabetes mellitus. Recurrent subconjunctiva hemorrhage should give us suspicion of leukemia and Kaposi sarcoma. Sometimes there are large subconjunctival hemorrhage which due to fracture of the base of the skull and the floor of the orbit. And the characteristic feature of this large subconjunctival hemorrhages are we can't trace its posterior margin. And most of the subconjunctival are self-limiting, and we can start vitamin C tablets and lubricating eye drop as an adjuvant treatment. So this is how subconjunctival hemorrhage looks, but these are the various types of subconjunctival hemorrhage which I am telling. This is the large subconjunctival hemorrhage of which posterior margin we can't trace due to any floor fracture or orbital fracture, and sometimes petechial hemorrhage which occurs after conjunctivitis, and moderate hemorrhages which occurs after any systemic diseases and non-traumatic causes. Now the conjunctivitis, there are various etiological classifications. Conjunctivitis is divided into etiological classification and clinical classification. So etiological classification of conjunctivitis is infective, which can be due to bacterial, chlamydial, viral, fungal, parasitic, protozoal. It can be allergic, it can be irritative, it can be due to traumatic, and various other unknown etiology. Clinically, according to the presentation, catarrhal, bucopurulent, purulent, serous, angular, membranous conjunctivitis, pseudomembranous conjunctivitis. So there are various such type of different clinical classification of conjunctivitis depending on the type of presentation. Papillary conjunctivitis will show papilla, follicular conjunctivitis will show follicles. So I will be going into all these details in the upcoming slides. Before to start with the conjunctivitis, we should know the various type of conjunctival congestion. So these are the various type of conjunctival congestion which is should be is required for for better understanding of conjunctivitis and for differential diagnosis of various other clinical conditions. So this is the this is how various type of conjunctival congestion looks. And angular conjunctivitis congestion is around the angle. Inflectional conjunctivitis near limbus. Circumciliary conjunctivitis in keratitis. Circumciliary congestion in keratitis. So to start with bacterial conjunctivitis. Bacterial conjunctivitis is due to various type of bacteria which we know, Staphylococcus, Streptococcus, and it is due to flies, poor hygienic condition, dirty habits and poor sanitation. Most common symptoms in all conjunctivitis are mostly same, like discomfort, foreign body sensation, mild photophobia. Discharge can vary, there is variation discharges like mucopurulent, purulent, serous according to type of conjunctivitis, sticking of lid margins, and blurring. Sometimes it can, when cornea is involved, there can be blurring of vision. But signs are can be conjunctival congestion, chemosis, petechial hemorrhages, flecks of mucopus, and matting of eyelashes. This is the various type of bacterial conjunctivitis, which is will be going in upcoming slides. So this is the picture with discharge showing in it, matting of eyelashes, lid edema. This is the presentation of bacterial conjunctivitis. Treatment is mostly broad spectrum antibiotics, irrigation of conjunctival sac, dark goggles, no bandage, no steroid should be given in such cases. Now, the purulent conjunctivitis, acute purulent conjunctivitis is mostly due to gonococcus, and it mostly complicates because gonococcus, this is a very important question, MCQ, can be asked in Viva question, because gonococcus have a tendency to attach to the epithelium of the cornea. So, corneal involvement is is the most common involvement, and hence complicate this type of conjunctivitis. And if it is not managed properly, iridocyclitis and sometimes systemic conditions like arthritis, endocarditis, and septicemia is also associated with this condition. This is how the corneal involvement in acute purulent conjunctivitis due to gonococcus looks like, with profuse purulent discharge. Now, the ophthalmia neonatum. Ophthalmia neonatum is a conjunctivitis which occurs in the neonates, in children aged less than 30 days. It is any discharge or watering in the first week of life should arouse suspicion of ophthalmia neonatum. Now, the etiology of conjunctivitis in neonates can be due to in before birth, reason can be infected amniotic fluid, during birth due to infected birth canal, after birth it can be due to soiled cloth, unhygienic condition during first bath. So this is very important question, and also it helps in sometime in pediatrics and obsgyne people. It helps in diagnosis of when resident goes for on call. So this type of condition they can see, so they can help. This table will help the resident to differentiate which type of conjunctivitis it is. So within the first 48 hours, if it is there, it can be due to Neisseria gonorrhea, and treatment is ceftriaxone injection, intramuscular, gentamicin eye drop, bezitracin eye drop. So mostly Neisseria gonorrhea related ophthalmia neonatal present within first 48 hours. Within 48 to 72 hours, if it occurs, it is occur due to other bacteria, and the treatment is due to can be given is neomycin, bezitracin ointment, and gentamicin drops, tobramycin drops. Within 5 to 7 days presentation, it is mostly due to herpes simplex virus, and the treatment is acyclovir 3% ointment. And if it present after 1 week, it is mostly chlamydia trachomatis of serotype D2 to K, and the drug of choice for chlamydia is erythromycin ointment. And this is the clinical presentation of ophthalmia neonatum: pain in tender eyeball, swollen lids, chemos conjunctiva, cornea involvement may occur, and complications due to corneal involvement can occur, like perforation of the cornea. Prophylaxis can be given to during antenatal by treating the genital infection of the mother. During delivery, under aseptic condition should be done, and newborn eyelid should be cleaned. And postnatally, we can give 1% tetracycline or 0.5% erythromycin ointment for prophylaxis to prevent ophthalmia neonatum. So the most important question in ophthalmia neonatum is differential diagnosis. Clinically, 3 conditions look same: ophthalmia neonatum, like conjunctivitis in neonates, and congenital nasolacrimal duct blockage and congenital glaucoma. These three conditions can mimic each other, but it can very well can be differentiated, because in congenital nasolacrimal duct blockage, regurgitation test like regurgitation on pressing lacrimal sac area, we will see positive regurgitation test, while in ophthalmia neonatum there will be no RT positive. But and also in how can we differentiate congenital glaucoma of ophthalmos from ophthalmia neonatum? In congenital glaucoma, there will be no discharge, there will be large eyeball, large cornea, watering will be there, but there will be no discharge. So in this way, we can differentiate the three condition: ophthalmia neonatum or neonatal conjunctivitis, and congenital nasolacrimal duct blockage, and ophthalmos. Now, the acute membranous conjunctivitis is mostly conjunctival inflammation with formation of a true membrane, and it is mostly occurs due to Corynebacterium diphtheria due to deposition of the fibrinous exudate on the surface of substance of conjunctiva, usually on the palpebral conjunctiva. This is how membranous conjunctiva look, and it is always should be differentiated by pseudomembranous conjunctiva, which I will be dealing in upcoming slide. Clinical features are mostly stage of infiltration, suppuration, and cicatrization is there. Complication may occur due to corneal ulceration and delayed symblepharon. Delayed complications like symblepharon, tracheasis, entropenia can occur. Treatment is penicillin eye drop, antidiphtheric serum, atropine 1% ointment if cornea is involved, and broad spectrum antibiotic ointment at bedtime. Systemic crystalline penicillin 5 lakh unit intramuscular BD can be given for this condition. And this condition may mimic acute pseudomembranous conjunctivitis, which is mostly due to different bacteria like Staphylococcus, Streptococcus, and viruses like herpes simplex adenovirus. It mimics membranous conjunctivitis, but there is difference between pseudomembrane and membrane. So what is this? This is very important to clinically, and in exam it can also come. Clinically, membrane bleeds while peeling. We have to bleed during management. We have to peel this membrane or pseudomembrane for better penetration of antibiotics. So while it will bleed while peeling true membrane, and it because the coagulum involves conjunctival tissue, and hence it is difficult and painful to peel, whereas pseudomembrane do not bleed while peeling. Coagulum does not involve conjunctival tissue. Because of this, it doesn't bleed and is always easy and painless to peel. Now, the next conjunctivitis is chronic catarrhs or simple conjunctivitis, mostly due to chronic exposure to smoke, dust, chemical irritants, local irritants like trichiasis, concretion, foreign body, alcohol abuse, eye strain due to refractive error, and causative agent mostly Staphylococcus aureus commonly. Symptoms can be mild foreign body sensation. There is only watery discharge, and treatment is mostly broad spectrum antibiotic can be given for 2 weeks with astringent eye drop, zinc boric acid for symptomatic relief. Now, the angular conjunctivitis, it is mild chronic conjunctivitis confined to the angle, and the most and it is can ask be in viva, which organism is responsible for angular conjunctivitis is Moraxilla accentrale, which causes redness in the angle of the eye. Here the congestion and redness is mostly at the angle, medial canthus, hence the name is angular conjunctivitis. Hyperemia of the bulbar conjunctiva, lid margin, excoriation of the skin near the angles can be seen in this. Good personal hygiene can be given is the management, and oxytetracycline 1 ointment on zinc and zinc lotion at daytime and zinc oxide ointment at bedtime is the treatment. Now, the chlamydial conjunctivitis, to start with, this is the classification of chlamydia. Different types of chlamydia, chlamydia trachomatis. Now, this is the classification, very important zones classification for chlamydial conjunctivitis, which includes banding trachoma occurring due to trachoma of serotypes AB, BAC, chlamydial trachomatis, and non-blinding trachoma due to chlamydia serotypes AB, BAC, chlamydial trachomatis. It is usually associated with mild bacterial infection, mild disease, and paratrachomas with serotype of chlamydia D2K. Now, the trachoma is very important question, and sometimes it can be asked in MCQs also, formerly called Egyptian ophthalmia. And trachoma word is from Greek word trachoma, which is due to rough. And the most characteristic feature of trachoma is it has both mixed follicular and papillary reaction. In no other conjunctivitis, you will see both follicles and papilla. Papillary reaction. Papillary reaction alone can be seen in allergic conjunctivitis, and follicular reaction alone can be seen in viral conjunctivitis, which I will be coming in my upcoming slide. But both follicular and papillary reaction always we will see in trachoma. Etiology is mostly chlamydia trachomatis. Source of infection is due to discharge of the affected person, and mode of infection is by direct spray, airborne or waterborne mode, vector transmission by flies, and unhygienic condition, socioeconomic poor social status are the predisposing factors. Most commonly, trachoma will be having minimal symptoms, mild foreign body sensations, mild stickiness of lid, but it can be blinding trachoma when this infection is superadded with secondary bacterial infection, all typically symptoms of acute bacterial conjunctivitis. So the conjunctival signs of trachoma are mostly congestion of upper tarsal fornical conjunctiva, conjunctival follicles, papillary hyperplasia, conjunctival scarring, and concretion. What are these? I will be telling in upcoming slide. And corneal signs are mostly superficial keratitis, Herbert follicles, pannus, corneal ulcer, Herbert pits, corneal opacity. Now, this is a very important question, and this we should understand what is follicles and what is papilla. So follicles, they look like boiled sago grain, which we eat in Hindi. We can say it's like sabudana. Boiled sago grain appearance is of follicle, and it looks like white. Why they look like white? Because it occurs from histopathologically. It is scattered aggregation of lymphocytes, multinucleate giant cells, Leber cells, mononuclear histiocytes. So this due to aggregation of these cells, it looks like boiled sago grain appearance, and it mostly seen in the tarsal conjunctiva. Hence, when we evert eyelid, we see such thing, and these are known as conjunctival follicles, which is mostly seen in mostly seen in viral conjunctivitis, but can also be seen in trachoma along with papillary hyperplasia. Now, what is papilla? Conjunctival papilla is red, flat top raised areas. These are red areas in contrast to the follicles, which are white areas, and these occur due to central core of numerous dilated blood vessels surrounded by. These are red because lymphocytes are aggregated around the numerous dilated blood vessels, and these dilated blood vessels give red color to this papilla, and hence it helps in differentiating from follicles. So these are the differentiating feature of papilla and follicles, which I have told you right just now. Arts line is the conjunctival scarring at the palpebral conjunctiva is the other characteristic feature of trachoma. Concretion, these are accumulation of dead epithelial cells and inspissated pus and depression called glands of Henle's. Herbert follicles are similar to conjunctival follicles but are present in the limbal area, and when these follicles get scarred, this looks like pit, and these are known as Herbert pits. Pannus is the blood vessel in the cornea. Infiltration of the cornea associated with the vascularization in the upper limbal area. These vessels lie between epithelial and Bowman's layer. These are of two types, progressive and regressive, where infiltration is ahead of vascularization in progressive, and vessels extend short distance beyond infiltration in regressive. Now, the McKellen classification, which is very important for staging of trachoma, which is incipient trachoma, established trachoma, cicatrizal trachoma, and healed trachoma. Now, the Fisto classification of trachoma is very important, where F for follicular reaction, where when follicular reaction is there, it is F stage. Intense inflammation, pronounced inflammatory thickening of upper palpebral conjunctiva. Trachomatous scarring, when scarring occurs, it is a this stage. Trachiasis, that is inward turning of even one eyelash, and is known as trachomatous trachiatic stage. And corneal opacity, easily visible corneal opacity present in the pupillary area due to rubbing of eyelashes, and this is the Fisto classification of WHO. Sequelae of trachoma is that's why trachoma is blinding, because of the complications, and the complications are in lid. It can be trachiasis, entropy, tylosis, ptosis, medullorosis. In conjunctiva, due to concretion, sidosis, xerosis, and similar from in cornea, corneal opacity can cause xerosis and corneal pannus, and other complications like chronic dactylocystitis and adenitis. Management of trachoma is topical tetracycline ointment. Systemic therapy can be tetracycline or erythromycin QID orally, or doxycycline or single dose of azithromycin orally, or combined therapy can be given. Management sequelae can be managed as like removal of concretion can be done, epilation or electrolysis of trachiasis can be done, correction of entropion and lubricating tropha xerosis can be done, and prophylaxis by maintaining hygiene can be done, and early treatment of conjunctivitis can be given by blanket antibiotic therapy in endemic areas of 1% tetracycline ointment BD for 5 days in a month for 6 months. And the safe strategy for the management of trachoma blindness is S for surgery, A for antibiotics for acute infection, F for facial hygiene, and E for environmental changes. Other chlamydial conjunctivitis include adult inclusion conjunctivitis, which is due to chlamydial trachomatis serotype D2K. It is primary source of infection due to erythritis cervicitis, and also known as swimming pool conjunctivitis. Incubation period is 4 to 12 days. Again, symptoms are mostly same: foreign body sensation, photophobia, mucopollen discharge. Treatment is again tetracycline 1% ointment, QID for 6 weeks. And systemic therapy can be given either tetracycline, erythromycin, doxycycline, or azithromycin 1 gram as a single dose. Viral conjunctivitis, most viral infection conjunctivitis can convert into keratoconjunctivitis, and mostly due to adenoviral conjunctivitis, herpes simplex keratoconjunctivitis, herpes zoster, pox virus, myxovirus, and paramyxo. Clinically, this viral conjunctivitis is divided into acute serous conjunctivitis when the discharge is mostly serous type, acute hemorrhagic conjunctivitis, which is associated with subconjunctival hemorrhage, and follicular conjunctivitis, where follicles are seen in, as I have told you earlier, in viral conjunctivitis, follicles are seen. Other conjunctivitis, acute follicular conjunctivitis etiologies are adult inclusion conjunctivitis, which is non-viral, which is chlamydial; epidemic keratoconjunctivitis due to adenovirus 8 and 19; conjunctival fever due to adenovirus 3 to 7. This serovirus can be asked in the question in MCQs. Newcastle conjunctivitis and Newcastle virus, and acute herpetic conjunctivitis due to HSV-1-2. This is how follicular reaction sees in viral conjunctivitis, and sometimes cornea can get involved and SPKs can be seen. And the treatment is mostly antiviral, like acyclovir and acyclovir. Now moving on to allergic conjunctivitis. Allergic conjunctivitis is mostly simple allergic conjunctivitis, vernal keratoconjunctivitis, atopic keratoconjunctivitis, giant papillary conjunctivitis, flectanular conjunctivitis, and contact dermatoconjunctivitis, details of which I am going to. Most common and most important is VKC, vernal keratoconjunctivitis, clinically also and theoretically and exam-wise also. Clinically, we see such cases most commonly. First is vernal keratoconjunctivitis, also known as spring catarrh, which is a misnomer. It doesn't occur in the spring. It mostly occurs in summer. And it is recurrent bilateral interstitial self-limiting allergic conjunctivitis, and due to hypersensitivity to some exogenous allergen, and it is IgE mediated. And most it occurs in males, but it can occur in females, and between 4 to 20 age group. Conjunctival epithelial hyperplasia and marked infiltration in hydrinoid cell layer is seen in this. So palpable signs of VKC is, as we can see, as I have already told you what is papillas, and here there are large papilla which are arranged in cobblestone or pavement stone fashion, and this is the characteristic feature of VKC. And giant papillas can be seen with white ropey discharge, which is again a characteristic feature of vernal keratoconjunctivitis. The bulbar form of vernal keratoconjunctivitis show dusky red triangular congestion of the bulbar conjunctiva as seen in the picture, and gelatinous thickening of the thickened accumulation of the tissue around the limbus. A Trantas spot, which is the presence of discrete white reddish dot around the limbus, is seen in VKC. So there can be two types of bulbar and palpebral form of VKC, and sometimes both the features of VKC can be seen mixed. Now the vernal keratopathy which occurs in VKC is punctate epithelial keratitis, ulcerative vernal keratitis, vernal corneal plaque, subepithelial scarring, and pseudocurrent axon. VKC has self-limiting clinical course, usually goes off spontaneously in 5 to 10 years, but in acute phases it requires management. It mostly recurs when there is a climate change and during summers, and the differential diagnosis, as I have told you earlier, is trachoma with predominantly papillary hypertrophy, but follicular reaction will be seen in the trachoma. Treatment is local therapy, systemic therapy, treatment of the large papilla, and general measures. Desensitization and treatment of vernal keratopathy are the various type of modes of treatment. Treatment topically, we can give steroid under tapering dose, mast cell stabilizers, and topical antihistaminic eye drops can be given. And if it is a chronic conditions, we can start with topical cyclosporin eye drops, where steroid cannot be given for a long time. Now, the treatment, oral systemic therapy can be given, oral antihistaminic, oral steroid in severe cases for short duration, but mostly oral antihistaminics will do. Treatment of large papilla with supratarsal injection of long-acting steroid, cryo application, surgical excision of extraordinarily large papilla can be done. Now, the gel papillary conjunctivitis is a type of allergic conjunctivitis where there are some etiologies there like contact lens, prosthetic shell, and suture irritation. Constant irritation due to anything in the eye can cause joint papillary conjunctivitis, and signs are papillary hypertrophy and upper tarsal conjunctiva with hyperemia. The offending in the management of treatment of giant papillary conjunctivitis is treatment of the cause. Offending cause is, and steroids are not of much use in this condition. Flectinal conjunctivitis
Can
is
you wind
another
up
type.
fast, please?
Sorry.
Can you wind up fast?
Yeah, nodular affection, flectinal conjunctivitis due to delayed hypersensitive reaction, tuberculosis staphylococcus, and age group is 3 to 15. And there can be simple and miliary type of, the multiple flectins can be there. And topical steroid eye drop can be given, and diagnosis management of TB can be done. Degenerative condition of pingicula, pterygium, concretion. Pingicula mostly occur in age-related and strong UV light exposure area. It is due to elastotic degeneration of collagen fiber. It is bilateral, usually stable, yellowish white patch near the limbus, and no treatment is required. And we should just avoid sunlight. Pterygium is another degeneration, triangular wing-shaped fleshy fibrovascular mass or fold of conjunctiva encroaching upon the cornea from either side within the interpalpebral fissure. And the treatment is mostly surgical, and it is mostly due to cosmetic disfigurement, and can cause astigmatism. And when it is of when it covers papillary area, it can decrease the vision. Differential diagnosis pseudopterygium, and mostly surgical. There are various types of surgeries: Macronol's operation, and using biatomycin C, bare sclera method, surgical excision with free limbal autograft, and most recent advance is perfect pterygium extended removal with extended conjunctival transplantation. I think I'm running out of the time, so I will just cut short. Other some limbal dermoid. These dermoids are lenticular yellow tumors, usually astride the corneal margin, most commonly the outer side, and the surgical excision is treatment of choice. And bitot is for in xerosis. Dryness of conjunctiva is xerosis, and bitot spot is the characteristic feature. Xerosis is a dry lustreless condition of the conjunctiva due to deficiency of the mucin. Small triangular white patches on the outer inner side of the cornea and covered by the material resembling bright foam is bitot spot. It occurs mostly due to these foamy spots are due to gas production by Corynebacterium xerosis present in the epithelium, and it can be seen in vitamin A deficiency in malnourished. Dry eye is another condition which is multifactorial disease, and the ocular surface is characterized by loss of hemostasis of the tear film. It can be lipid deficiency dry eye, aqueous deficiency dry eye, and mucin deficiency dry eye. Aqueous deficiency, lipid deficiency due to meibomian gland affected, aqueous deficiency due to lacrimal gland affected, and mucin deficiency due to goblet cell. And it can occur in meibomitis is lipid deficiency. Jordan syndrome causes aqueous deficiency dry eye, and ocular cicatrice pemphigoid, Steven-Johnson syndrome can cause mucin deficiency dry eye. So thank you. These are my sources. Sorry, I exceeded the time limit.
Thank you, ma'am. That was really comprehensive. And the topic is actually, it's a very big topic and you covered it very nicely. So thank you so much for taking out precious time for this today's talk. So in the paucity of time, I would like to get to Dr. Sharmila if she wants to add on to any of the things that she has talked about.
A very elaborate topic, ma'am, comprehensively covered. Congratulations. And I would like to just add about the importance of povidone and conjunctivitis. Madam was mentioning about the different types of conjunctivitis in newborns, and based on the onset, how it's important to differentiate them: chemical conjunctivitis, herpes simplex, gonococcal, ophthalmia neonatum, and chlamydial. So based on the time of onset, is very important to differentiate. And she explained about the treatment. I would just like to stress upon the importance of povidone iodine, diluted povidone iodine to 0.5% or 1%. in addition with a mild soft steroid in viral conjunctivitis. So that might be very useful, and many systematic reviews and meta-analysis shows that PVPI with low potent steroid is very useful. And if in chronic SCI, you can also add a cyclosporin drops twice daily or a tacrolimus eye ointment. Another point that I want to stress is vernal keratoconjunctivitis. If it presents with a limbal stem cell damage, it can be really difficult to treat, and the patients can present to us for a very long time. And you need to be in touch with the patient and explain to them, how it can. That if once the limbal stem damage occurs, then it becomes very difficult if they go for a limbal stem cell transfer and other stuff. So it's important to catch them early and treat them with if at all you need a systemic immunosuppression tacrolimus eye ointment or systemic immunosuppression with the oral steroid 0.5 milligram per kg body weight, or sometimes the LUPI paper, LUPI group has tried oral cyclosporin. So that is very, very important, and those are the points that I would like to stress for. Thank you.
Thank you, ma'am. So I would like to invite Dr. Mallikarjun for talking about common signs in cornea and their clinical implications. Sir, can you please start your slides?
Before sir gets that ready, even limbal dermoid and all the conjunctival tumors are very important. Ocular surface squamous neoplasia can be kept. So it's important to differentiate the different ocular surface tumors, whether it's limbal dermoid, chorostomas. You should know the difference between a choristoma and a hematoma, and what are the different types of chorostomas, and ocular surface squamous neoplasia, the Shields technique and all that. So that's very important. I think due to paucity of time, she had to rush through it.
Yes.
Whether my screen is audible?
So you are audible, but we can't see your screen.
Okay.
So even limbal dermoid can be kept as a case for short
Yes.
case in some of the examinations.
So if it's unilateral or if it's bilateral, you have to know the syndromes associated with it,
Yes. Yeah.
the different syndromes.
And even OSSN, they can keep a short case too.
Yeah.
Yes. So do you need any assistance from the team?
Sir, I think you need to share the slides. There's a green button.
Can you see my?
We can
Yes,
see
sir.
your screen, but it is not full screen, sir. Can you make it full screen? Yeah, now we can see.
Yes.
Yeah. At the outset, I would like to thank AOS and GuruSangam team for this opportunity. I'm going to talk on common corneal signs and their clinical implications. Most often, the PG students, they find it difficult to elicit signs and understand why these signs are formed. So I have made this presentation considering the postgraduate students. I have no financial interest. Some tips to examine the cornea. So first you make a diffuse illumination and examine and look for any abnormality. Then make a slit beam and scan from one limbus to other limbus. That means from nasal to temporal side, and look for any abnormality and see what depth it is there, size and other morphological features. And always keep in your mind when you are examining, I am examining epithelium. Then go deeper, I am examining anterior stroma, then deep stroma. Now I am examining at a descent level, so that you will not miss any small signs also, and also you will correctly note what is the lesion and what level the lesion is there. And whenever required, use retro or sclerotic scatter or specular microscopy. For example, this is the cornea. Clear. It looks very clear in diffuse illumination. But when you make a slit image and look at the deeper layer, there is something is there in the endothelial side. So this is the beaten metal appearance, the earliest sign of Fuchs endothelial dystrophy. Most of the time, postgraduates, they will not be able to make out the epithelial signs. The main three epithelial signs are punctate epithelial erosions, subepithelial infiltrates, and superficial punctate keratitis. So I'll deal with three in one by one. First, punctate epithelial erosions. Punctate epithelial erosions means there are small epithelial defects. So there is no epithelium there, and there are very tiny epithelial defects. So when there is an epithelial defect, it takes a fluorescent stain. And also these lesions, depending on the location, we can also make some probable diagnosis. So what are the causes? So tear film deficiency can cause epithelial, small epithelial defects, mechanical trauma like VKC. VKC is there. There is a lot of giant papilla there in the upper tarsal. It causes a mechanical trauma to the epithelium and called PE. And chemical toxicity, neurotrophic dysfunction, or exposure to exposure keratitis. So when there is exposure, epithelium is not producing properly, and there might be small epithelial defect that will cause the PE. And depending on the location, see, if you stain the ocular surface, and if it is a diffuse, it can be due to viral conjunctivitis, trauma, toxicity. If it is in inferior, consider blepharoconjunctivitis, lag of thornos. If it is in the interpupillary area, consider dry eyes or exposure and neurotropic keratitis. If it is superior, consider supralimbic conjunctivitis. If it is at the 3 o'clock or 9 o'clock, consider contact lens. Or if it is a lower conjunctiva and lower cornea, consider mechanical or mammon gland dysfunction or drug toxicity. Another epithelial lesion is punctate epithelial keratitis. So you understand the terminology here. It is a keratitis. So when we use that keratitis, whenever there is an inflammation. So here there is epithelium is damaged, and also it is associated with inflammation. So it causes a epithelial cell edema. So there is a cell membrane damage without desquamation. The tight junctions are still intact. So there is no epithelial defect. So when there is no epithelial defect, it will not take the staining. So whatever staining that happens, it is not actual staining. It will be small pooling around the lesions. So what are the conditions it causes suprapunctate keratitis? Dry eye disease, mammon gland dysfunction, exposure keratopathy, lag of thermus, preservative toxicity, drug toxicity, other drug toxicities, blepharitis, viral keratitis, mainly adenoviral or early HSV virus, and allergic conjunctivitis. So basically, the difference between a PEE is SPK. There is PEE, we have a epithelial defect. Okay, tiny epithelial defect. In SPK, these epithelial cells are swollen. So that is the basic difference between a PE and SPK. Another condition is subepithelial infiltrates. You understand the terminology. It is subepithelial infiltrates. There are inflammatory cells below the epithelium. They are commonly located between Bowman's layer and the superficial trauma, typically beneath at the intact epithelium. When there is, because it is epithelium is intact, they do not stain with the fluorescein. So this is the typical picture of SPK. this is the post-viral conjunctivitis SP case. This is like the Tygason's superficial punctate keratitis. So most commonly causes are adenoidal conjunctivitis, herpes zoster keratitis, Tygason's superficial keratitis. And sometimes these SPKs, you see them for prolonged time. Why it happens? Because the corneal immune privilege is partially lost during inflammation in there. So memory T cells are re-trigger the inflammation. So these inflammatory process continues so that these subepithelial infiltrates, they tend to remain for longer time. Another sign is corneal abrasion. It is very obvious to make out. It is due to loss of epithelial cells in a larger area. So it is easily recognized by doing a fluorescence staining. So what are the causes for epithelial failure? Mechanical trauma, chemical injury, large foreign body, infective keratitis, contact lens related injury. See, sometimes if you see a epithelial defect in the superior cornea, there might be a foreign body in the upper tarsus. You have to invert the upper lid and see any foreign body therein. Filaments. What happens in filament? The corneal epithelium is damaged and it becomes devitalized. And when there is a devitalized epithelial cell, mucin and cellular debris accumulate on it. And these strongly, one side of the filament is strongly adherent to the cornea. And when there is a blinking process, this mucus will prolong, it will elongate it. So it forms the filament-like thing and with a tail. So since the base is attached to the epithelium, any movement of the eye or blinking, it will cause the pain. The causes are dry eye, supercilium keratoconjunctivitis, especially seen in the superior cornea, chronic dry eye diseases, chronic topical medication toxicity, or prolonged patching can also cause filaments. And usually, because this is a devitalized cells, it stains with the rose bengal. The vicious cycle of filament formation. First, there will be tearful instability, but plus epithelial damage. This leads to mucin adherent to the damaged epithelium. Blinking stretches the mucin strand and forms the filaments. Then further traction causes more epithelial injury. So new area of the epithelial damage. So more filaments are formed. Coming to dendrites. The actual meaning of dendrite is tree. So the lesion looks like a tree. So we can classify them dendrites into true dendrites and pseudodendrites. True dendrites always is due to HSV keratitis, epithelial keratitis. Why it is formed like that means the viruses invade the epithelial cells and they start multiplying and start eating the epithelial cells and they spread along the subepithelial nerve plexus. That's nerve plexus. So that's why it looks like a dendrite. So in the center of the dendrite, there is no epithelium because the virus has eaten all the epithelium. But in the periphery, it is still the replication of the virus is continuing. There it is still there are devitalized cells. So it will take a dual staining. That means in the center, it takes the rose fluorescein, and in the periphery, it takes the rose bengal stain. The terminal bulbs means the bulb-like lesions at the periphery of the dendrite. These are called as the terminal bulbs. And here there will be maximum replication of the viral cells. And the dendrites may be pseudodendrites also. The main differentiation here is there is no terminal bulb in there. So what are the causes for pseudodendrites? Herpes zoster ophthalmicus, healing epithelial defect, topical drug toxicities, early acanthamoeba keratitis, And even early fungal keratitis can also cause dendritic lesion. So you need to be very cautious in finding out the etiology of this dendrite. So this is the case of herpes zoster ophthalmica, herpes zoster keratitis, and this is the acanthamoeba keratitis, early acanthamoeba keratitis, and also we can see here perineuritis. So the lesion looks like a dendrite, and also there is a edge. It looks like a swollen like thing. So the nerves also are inflamed, and healing epithelial defect also looks like a dendrite. And another cause is early fungal keratitis. Infiltrates. Basically, infiltrates are accumulation of inflammatory cells with microbes or without microbes. They can be focal, diffuse, multiple at various depth. The infiltrates can be seen at the corneal epithelium, Bowman's layer, or at the stroma. These lesions arise because of microbes plus the antigens or toxins of the microbes, which incites the inflammation. So the picture is a combination of microbes and how much inflammation it incites into the cornea. So these infiltrates can be sterile or infective. Sterile means without any microbes causing it. What happens in infective keratitis? When there is microbial invasion like bacteria, fungi, acanthamoeba, and virus, the epithelium is breached and organisms enter into the stroma. The microbial start proliferating and it triggers the innate immune response. There will be massive neutrophil influx. This causes a stromal necrosis. Again, there will be release of protease, MMPs, reactive oxygen species, which causes stromal ulcer and melt. And there will be collagen breakdown, which causes thinning and perforation. So this is the example of staphylococcus ulcer. So this clinical picture depends on the how much inflammation it incites and how much damage the microbe itself causes on the cornea. Staphylococcus usually causes a small infiltrate, a single infiltrate, okay, and it doesn't cause much inflammation. And Pseudomonas causes more inflammation, usually start from the periphery and spreads to the center. All sometimes it is called as ulcus sulpans. And Pseudomonas cause very rapid inside rapid inflammation, and also the toxins released by the Pseudomonas. This causes a melting of the cornea, and even it can lead to perforation within short period. These are the pictures of sterile infiltrates. Sterile infiltrates can be multiple, peripheral. This is due to contact lens overuse, and this is a sterile infiltrate due to marginal keratitis. Then fungal infiltrates. Fungal infiltrates are raised, dry, feathery, and indolent. Why they look like that? Fungal cell wall resists of killing by neutrophils, and it causes slow and chronic immune reaction. And fungal IPA spread along the stromal lamellae. That's why there will be a feathery edges, and also it causes minimal necrosis. Since it incites less inflammation, the clinical picture also will be like this, and also it will be very long period. And difference between a sterile and infectious infiltrates. The cause is in sterile is immune mediated. It is in infectious, it is microbial invasion. Epithelial defect is absent or small in sterile infiltrate. It is large in or infectious keratitis or proportional. Pain is mild. It is severe in infectious. Size may be less than 1 to 2 millimeter, larger and progressive in infectious. Location is peripheral, and infection is commonly in central, or it can be anywhere. Discharge is minimal in sterile, and it is purulent in infectious. risk is minimal relative in sterile, and in infectious is usually high risk for ulceration and perforation. Common sign is corneal opacity. Corneal opacity is because of the end result of various insult to the corneal leading to loss of corneal transparency. Any loss of corneal transparency leads to, it is called as corneal opacity. Traditionally, they are classified into nebula, macula, and glaucoma. But what I would suggest is you have to measure the corneal opacity, look for the depth, location, and size, and or any secondary changes. That will help us to identify the etiology, and also it will help us to which surgery to do for it. If it is a superficial, only superficial opacity obscuring the visual vision, we can go for SALK. If it is a deep one, we can go for DALK likewise. So there can be secondary changes in corneal opacity. So whenever there are secondary changes in the opacity, it means the opacity has been there for a long time. So there's something called lipid degeneration. So there can be lipid deposition on the opacity, and it looks like a yellowish deposits on the corneal opacity. Always there will be some vascularization. So this lipid comes from this vessel and deposits on the cornea. And sometimes you see a clear lines in the opacity. These are the called as ghost vessels, and these are the regressed vessels in the corneal opacity. And some very long standing corneal opacity can go into for atherosclerotic ulcers, start melting in the center. So patient who has been less vision, who has a less vision for long period, suddenly starts getting watering, pain and all. It can be a atherosclerotic ulcer. And coming to the epithelial edema, these are diffuse microcysts at epithelial level, can be seen in diffuse and slit illumination. And if you make a retro illumination, it can be enhanced. So this is a retro illumination of a microcyst. So they are at the anterior level, looks like a very tiny cyst. So this is the case of epithelial edema. Why there will be epithelial edema? It can be due to raised intraocular pressure, hypoxia, or toxicity. When stromal imbibitor pressure becomes less negative and the stroma swells, the excess fluid pushes forward and it goes into the epithelium. There will be tight junction disruption of the epithelial cells, and there will be accumulation of fluid in the intracellular level and also extracellular. This causes the microcyst. The microcyst may coalesce and form a bulle, and bulle may rupture and cause the epithelial defect. What are the causes for epithelial edema? So endothelial decompensation, like in a fuchs endothelial dystrophy. So if it is there for a prolonged period, so there will be a lot of fluid collection in the stroma. This will come into the epithelium. And acute rise in intraocular pressure, like in acute angle closure glaucoma, post cataract surgical endothelial trauma, and contact lens induced hypoxia. And some drugs which causes a toxicity on the epithelium can also cause the epithelial edema. Coming to stromal edema, the stromal edema can be diffuse or localized. So in the diffuse stromal edema, how to identify it? So the cornea looks very hazy, and it appears like a ground glass appearance. And when you make a slit and see, the cornea looks like a slower. So there will be increased thickness, and there will be loss of normal corneal transparency and crisp optics, and the iris structures will not be seen in detail. So what are the causes for diffuse corneal edema? Fuchs endothelial dystrophy, pseudophakic or aphakic bullous keratopathy, acute angle closure glaucoma, long-standing severe glaucoma, TAS, endophthalmitis, chemical injury, contact lens hypoxia, and localized stromal edema. So edema can be localized also. How to identify this? Make a slit. See somewhere, you see in the diffuse illumination, you see something is there is a haziness is there in a particular area, and make a slit and see, compare this thickness with the area of edema. So there will be, this thickness will be increased compared to this. So there might be a, so there is a localized corneal edema. So what are the causes for localized corneal edema? See, this is a, this is a post cataract surgery. There is a some DM is detached here, so it causes wherever the DM is detached, it causes a localized corneal edema. And this is a central edema, stromal edema, and associated DM folds. This can be, the picture looks like a disc. So this can be a disciform keratitis caused by virus. And this one is a inferior only, there is a stromal edema. So this can be due to immune-mediated viral stromal keratitis. So what are the causes for localized stromal edema? Localized endothelial trauma, like surgical instrument touch, Descemet membrane issues, like local Descemet membrane detachment, hydrops in keratoconus, focal inflammation due to infection, microbial keratitis or viral stromal keratitis, overlying epithelial problem. If there is localized epithelial defect, there might be a localized stromal edema surrounding that. Recurrent corneal erosions with focal stromal hydration. It is very important to differentiate between a stromal edema, opacity, and as well as a infiltrate in the same cornea, because this will help us to know whether the infiltrates are healing or is there any recurrence of the infection, and how it, whether it is responding to our treatment. One example I'll give you. See, this is a healing infiltrates. Here there are still active infiltrates. This, and here there is a opacity is formed. So when you make a slit lens, see, the wherever there is a opacity, it is flat. It is not, and it is, and wherever there is a infiltrate still pulsing, it is still swollen, and also you can see the infiltrates. Coming to corneal vascularization. Corneal vascularization can be superficial vascularization or deep vascularization. So superficial vascularization is due to inflammation at the ocular surface. What happens? Superficial VEGF is increased. So from the conjunctival vessels, they grow into the epithelial side, and they breach into Bowman's layer and form the superficial vascularization. The deep vascularization is due to stromal diseases. Here there will be activation of deep limbal vascular plexus, and they enter into the deep of the cornea and form the deep vascularization. How to differentiate between a superficial and deep vascularization? Superficial vascularization looks red. They are subepithelial up to Bowman's layer, and the vessels continue into the conjunctiva. You can trace the vessels up to into the conjunctiva, and they are arborizing pattern, and deep vascularization looks deep red, like purple blush like, and they are seen at the stromal level, and they abruptly end up the limbus. So you cannot trace them in the conjunctiva. That's how we differentiate between a deep and superficial vascularization. And causes for superficial corneal vascularization. This is basically due to surface problem, like contact lens induced hypoxia, flexural keratoconjunctivitis, vernal keratoconjunctivitis, chronic blepharitis, chronic dry eye trichiasis, superliminal keratoconjunctivitis, and causes for deep vascularization, because basically due to a stromal problems, interstitial keratitis, herpes simple stromal keratitis, peripheral ulcer keratitis, corneal graft rejection, and cerebral chemical injuries. Pannus. Pannus is growth of the blood vessels plus fibrous tissue from the limbus into the superficial cornea. It is usually in the superficial layers of the cornea. The pannus can also be classified into progressive, stationary, and regressive. Progressive means vessels advance toward the center. Stationary means vessels stop progressing and remain stable. Regressive is vessels reduce and the pannus is regressed. The pannus indicates chronic inflammation of the cornea located in the superficial corneal layers. So what are the causes for pannus formation is trachoma, contact lens related hypoxia, flectinosis, ocular surface inflammation, chemical injury, limbal stem cell deficiency. This is one example of pannus. It is actually limbal stem deficiency. It started here and patient lost the follow-up. See how it is pannus is growing down. So this is a progressive pannus and it completely covered the cornea. So pannuses can also be small like this and because of various causes. And striate keratopathy and DM folds. Striate keratopathy is corneal edema with DM folds. When there is a corneal edema and DM fold, it's called a striate keratopathy. It happens, why it happens means following post-cataract surgery, if there is instrument rupture, and if there is endothelial dysfunction, severe inflammation in TARS, example TARS. And also you should be able to differentiate between striate keratopathy and only DM folds. So when you see the only DM folds, it can be due to hypotony or early localized DM detachment or mechanical pressure on the cornea. During surgery, you put a speculum, it will be tight, you can see the DM folds. Now coming to the deposits, the most common deposit we see is iron. So the Stocker's line, it is seen at the edge of the pterygium. Fletcher's ring, it is at the base of the cone in keratoconus. And Ferry's line, it is seen at the edge of the filtering bleb. And Hudson-Stanley line, it is commonly seen in old age. So common factor in all this condition is a elevated lesion or irregular cornea. Whenever there is an elevated lesion or irregular cornea, there will be tear film stagnation in any area of cornea due to irregularity in the tear film distribution. On stagnation of tear film, iron concentration increases and causes fabric iron uptake into basal epithelial cells, forming characteristic brown pigmented line. Band-shaped keratopathy. So name itself suggests it is a band-shaped and it is usually seen in the interpalpebral area and there will be lucid interval. Lucid interval means there is a clear cornea between the limbus and the band keratopathy. And also you can see a small holes in a small clear hole-like things in the band keratopathy. This indicates the superficial nerves entering into the deep plexus. Here the calcium will not deposit. Why it happens at the interpalpebral area? The interpalpebral area is where the maximum evaporation of the tears happens. When there is a increase evaporation of the tear becomes more alkaline. So the conditions where the calcium is more, in that condition, the alkaline environment makes it to enter into the cornea and deposit in the superficial layers of the cornea, especially at the Bowman's layer. So what are the causes for the band keratopathy? Chronic anterior uveitis, severe chronic keratitis, silicone oil in the AC, or phthisis bulbae. And DM stretch lines. These are due to buckling effect because of abnormal stretching of the cornea. So this can be seen in a keratoconus. These are vertical lines, very fine, and when you apply pressure, they disappear. And it can also be seen in congenital glaucoma, they call as Hab striae. These are usually horizontal and little bit larger.
Sir, I think
And
we
in
are a
birth trauma
little
also, we
less
can
on
see
time.
in birth trauma also, we can see the This is my large side. We can see the DM stretch line, and usually they are vertical chords. And when you make a retro illumination, this can be more enhanced. Thank you.
Thank you so much, sir, for that comprehensive clinical pearls. We all encounter such corneal lesions in our day-to-day practice, and it is very important to differentiate them. May I request Dr. Sharmila ma'am for her inputs?
I think, sir, that was a very excellent comprehensive coverage with a lot of focus on clinical pulse and exam questions. I'd just like to emphasize that it should be a complete ophthalmic examination, not just an ocular examination. Many times, what the students do is when they see a corneal lesion, they just shine the torch and put the slit lamp directly on the point of focus. It's very important to do a complete ophthalmic examination, which involves which includes the lid adnexa, like what sir said. And no ocular surface examination is complete if you don't invert the lid and see the fornix. And you might miss a lag of thalmus in a case of keratitis if you're not going to see the closure of the eyelids. And you should ask the patient to close. You can miss the lesions on the face. So it's very, very important to do a complete examination, general examination, as well as an ophthalmic examination. And I think it's very important to know the corneal epithelium anatomy, the layers of on the corneal epithelium, to understand the staining patterns, the hemidesmosomes attachment. How are the hemidesmosomes attached? How are the desmosomes attached? Sir explained very beautifully about the punctate epithelial erosions, punctate epithelial keratitis, and the SCI. So if you understand the epithelial, corneal epithelium anatomy and the hemidesmosomes, we can understand the staining pattern well. And there were a lot of the ring infiltrate differential diagnosis and all. It's very good in payments. So the differential diagnosis, you can go through that. And the corneal vascularization part, I think it's very, very important now, and it's caused a paradigm shift in the management because high risk vascular grafts are grafts which have more than 1/4 of vascularization. So the superficial vessels and all can be managed with the fine needle diathermy, intrastromal Avastin, and subconjunctival Avastin. So all this is lead to a paradigm shift in the management of high-risk grafts before taking them for keratoplasty. And before taking them for keratoplasty, it is important to see the level of depth of the lesion, and anterior segment OCT helps a lot in all of that. Those are the few points that I want to add. Thank you.
Thank you, ma'am. With this, we'll move on to our next speaker, Dr. Chandra Chakrabarti, ma'am. She will be speaking on approach to a case of conjunctival lesions. Over to you, ma'am.
Thank you. Thank you, all the distinguished AIUS office bearers, the panelists. I just want to share the.
The slides are visible, ma'am. Can you make it full screen?
Yes. স্ক্রিনে যাও এখানে যাও এটাতে শেয়ার করো ফুল স্ক্রিন করে দাও স্টার্ট ইনসার্ট করে সেখান থেকে স্লাইড শো করো Yes.
You can click on the slideshow.
Is it okay?
Yes, ma'am. Yes.
Can I start?
Yes, ma'am.
Good evening, everyone, the respected panelists.
Good evening.
So next half an hour, I'm going to talk on approach to a case of conjunctival lesion. My previous speakers have already described a lot regarding this conjunctival anatomy, the diseases, nice photos and documents. So I think they have made my job easy. I'm going to talk on relevant anatomy and introduction. I'm not going to talk again because this is already described by my previous speakers. I'll just go directly. These are my slides. I just classification of conjunctival lesion. There are various classification in literature. This one, I thought this may be a bit beneficial for discussion. Congenital, maybe limbal choristoma, limbal dermoid, dermolipoma, degenerations already spoken by all. Then inflammatory, conjunctivitis, rhinosporidiosis, infective one, squamous papilloma, and the most important one, the neoplastic. Neoplasia may be epithelial, melanocytic, vascular, lymphoid tumors, and secondary metastatic, and others. In inflammatory infective, just it is important to identify what is a follicle. These are the follicles, as you can see. They are the color of the follicle and the color of the papilla. You can see they are quite different. These are actually the cobblestone papilla. They are flat topped. What is this lesion? This is a pseudomembrane. In a case of it can occur in pneumococcal conjunctivitis, or it can occur in viral also sometimes. These are the Horner Trenta spots, pseudoxeron toxon. These are the bilateral flictenbular conjunctivitis. I want to show this one, the nodules around the limbus. If you see a nodule around the limbus, it could be because of some conjunctival disease, or it could be due to some disease of the sclera and episclera. Coming to the flictenular conjunctiva, this see the disease of the conjunctiva, the flictenular or vernal conjunctivitis, pterygium, pinguicula, tubercular, syphilitic, and foreign body granuloma, dermoid, implantation or parasitic cyst, papilloma, lymphoma, hemangioma, squamous cell carcinoma, nevus, malignant melanoma, Kaposi sarcoma, filtering bleb. All these can be seen at the limbus. Nodule around the limbus in scleritis, episcleritis, or intercalary or ciliary staphyloma may be seen. Coming to rhinosporidiosis, these are not very frequent, but sometimes you can see in the eyelid or in the conjunctiva, highly vascular soft tissue mass caused by Rhinosporidium severi. They are found in warm tropical countries. Found young adult mostly affected. Definite diagnosis is done only by HP, but a diagnosis clinically can also be done, because as you see these white dots, these are very characteristic feature of rhinosporidiosis, I mean. They may be conjunctival or in the eyelid. Treatment protocol, what to do, you cut this and do cauterization and send for the HP. But they are notorious to recur also, that you have to keep in mind. These are some pterygium and pinguicula already discussed. I'm not going to discuss them, but sometimes you have to just keep in mind that sometimes you may have to do differential diagnosis in other cases for this aggressive or progressive form of the pterygium. You have to do differential diagnosis. Coming to the choristioma. What are choristioma? Choristioma are the abnormal tissue in normal location. They are congenital lesion. They are seen in the early childhood. They are solid dermis-like collagen, sweat glands, hair, sebaceous gland, and fat globules may be seen within this. Sometimes they may be keratinized on the surface. You can see sometimes here on the surface. Commonest location is inferonasal. Inferotemporal is the commonest location, as in this case. They are in 75% condition inferotemporal, you will see. Other location can also occur. Bilateral is seen in inherited condition. These are dermolipoma. These are, I'll come to the limbal dermoid a bit thoroughly. Dermolipoma, let's see, fat is prominent. That is the different, and the color of the dermoid and the dermolipoma is also different. Sometimes they may need debulking, but not always. While doing debulking, you have to keep in mind that you should not injure the lacrimal gland and the lateral rectus muscle. And you may have to differentiate it from the prolapse of the fat in some cases. But fat prolapse is a bilateral condition, though dermolipoma is also a bilateral condition. There is a cleavage line is seen in case of dermolipoma, and in the prolapse of the fat, if you press the cornea or the globe, then it will increase in size. Look at this figure. This is a dermoid, this is a choristioma, but the more vascular choristioma, and the contents are also, in these cases, are slightly different, not the usual dermoid what we get. The less fat and other things maybe they are in this. They are multifactorial in origin. Very rarely, more than one family member have been seen. Management-wise, these are, if it is a small, very small one, then you can do, these are the grading. This will depend, the management will depend on grading of the limbal dermoid. Suppose the grade 1, it's a very small one, less than 5 millimeter, like in this case, you may not do anything. You can wait till the child grows, and if there is astigmatism, then you have to do surgery. But if it is a grade 2, that is more than a 5 millimeter in size, covering more than half of the cornea, and it is deeper, then you have to do surgical intervention. Otherwise, you may not do it if the patient let the child grow older. Sometimes it can cause delay in stromal hydration. Those are the conditions where you have to go for intervention actually. This is the grade 3. This is grading is basically we have to depend on UBM, ultrasound biomicroscopy or OSSCT for this grading. Let's see some syndrome which are associated with the golden hair, this limbal dermoid. This is the golden hair syndrome. The golden hair, remember that this is always unilateral. If you see a bilateral dermoid, that means it is some other syndrome, not golden hair. It is, the another name is oculo-auriculovertebral syndrome. It is associated with limbal dermoid, coloboma of the eyelid, the anotia or microtia as seen in this case, or a tag in the eyelid, or pre-auricular tag. These are maybe seen. These are some other photos where the dermolipoma and the limbal dermoid, they may be present at the same time. In these cases, cosmetic look, astigmatism, for all these things, you have to do surgical intervention by excising it. Other association, Treacher-Collins syndrome, Duane syndrome. This is another, recently I've seen this case, epidermal nevus syndrome. Remember that dermoid, they are not potentially malignant. But in some condition, like in epidermal nevus syndrome or nevus sebaceous abjadation, when the dermoid is associated with the microphthalmia, alopecia, then there is a malignant potential for these conditions. These are some of the cases where we have done surgery. The simple excision with amniotic membrane transplant. In a case of grade 1, associated limbal, there is no limbal dermolipoma at the lateral angle, and the eyelid coloboma. Tengel's flap was done. This was a 1.5-year male, in which case actually it was a case where we found that this is, the UBM also shows that it is a full thickness. So we had to do the surgery in that case, but the child is doing well. This is a bit of surgery we can see here. This is another case. After giving retrovalvular block, a thorough dissection is needed. You have to be careful after doing this dissection. See, the dermoid is separated. You have to be very, very careful. There is every chance of perforation of the cornea. So that you have to take care. And as it is the grading is very high, grade 2 limbal dermoid, that you may, there is a DALC was done in this case. So after the surgery, these are the complication: persistent epithelial defect, corneal vascularization, corneal scarring, pseudopterygium, incomplete excision, maybe globe perforation, and postoperative astigmatism can occur. Coming to the vascular lesion, these are very common lesion, the vascular lesion. This picture, this capillary hemangioma, this I took from Google. This is not my picture. The rest of the picture, this is a capillary hemangioma. These may be alone or may be associated with orbital hemangioma sometimes. This this is not my picture. This is a Google picture. Hemangioma, large size hemangioma, surgically removed. These are AV malformations. Sometimes you may mistake it with a serious thing, but these are AV malformation. These are innocuous. These are excision can be done just for cosmetic purpose. Valsalva maneuver has increased, and these are varix of the eyelid actually, but if after Valsalva maneuver, it increases through the conjunctival aspect. So there is a communication between the blood vessels. This is a low flow malformation. Pyogenic granuloma. These are very common actually. Look at the figure. How will you identify this is an acute or subacute onset? I mean 3 weeks to 1 month. The fleshy nodule easily bleed. They can be seen after the trauma, like in this child. At the suture site, they can be after the Calassian surgery or busted callosian, or in an anophthalmic socket, or after pterygium surgery, or after RD surgery. The scleral buckle was exposed, and these are benign vascular proliferation. They are easily distinguished, but sometimes you can confuse with some other lesion like squamous papilloma. The treatment done, if it is a very small tumor, you can treat with topical timolol, topical steroid, intralesional triamcinolone. If it is a larger one, then you have to go for surgery. Or in recurrent cases, low-dose brachytherapy to be given. This is the newly formed blood vessels. They produce this type of the lesion. Coming to the venolymphatic malformation, this may be situated only at the conjunctiva, or sometimes it may be continuous with the orbital venolymphatic malformation. They are no flow malformation. We treat by either by injection, bleomycin. And this is the case where we treated with the sodium tetradecyl sulfate. After 1 month, this is the picture. Has improved a lot. Surgical debulking also sometimes may be needed. Coming to the epithelial lesion, benign, precancerous and malignant. In the benign, epithelial inclusion seeds, pseudoepitheliumous hyperplasia, squamous papilloma. Precancerous, xeroderma pigmentosa, leukoplakia, actinic keratosis, and malignant one, invasive squamous cell carcinoma, mucoepidermoid carcinoma. Let's see one by one the picture. This is a 6-year male who came with a single lesion at the fornix. There are some, this is actually, this is a pedunculated lesion. Once you pick up it, you will see that there is a peduncle, but it may be sessile or pedunculated. They may be multiple also. This in case of children, they are benign condition. There is no chance of malignancy. But in case of adult, there is chance of malignancy is there. This hairpin vasculature is actually very characteristic of the papilloma. Sometimes they are associated with the human papilloma virus, and conjunctival papilloma has been documented in 5 to 45% of the cases. In case of adult, if you look at this picture, I borrowed this picture from Dr. Sanchita Roy. This squamous epithelium over the connective tissue front. See, look at the lesion, multifocal in the tarsal conjunctiva, the upper and lower, the pharyngeal conjunctiva. HPV 6, 11, and 16, they are associated with this type of the lesion, glistening, transparent. They are sometimes seen in immunosuppressed patient. It has a very low malignant potential. This is another patient. You can't treat it. This patient was actually treated after surgery. The patient was treated with interferon, and this was the final result at the end of 6 months. You can treat it with other antimitotic drug also. Sometimes cryotherapy, if it is a very small one. Mitomycin, interferon, all these have been tried. Coming to the epithelial inclusion cyst. After surgery or trauma, sometimes you can see that there is an inclusion cyst. Look at the cysts. Sometimes they can present only swelling in the eyelid. If you invert the lid, you can see this type of the picture. They may be clear fluid, or sometimes it may be bluish also. Look at this. These are actually difficult to do surgery because they are very much inflamed, and there is chance of, if when you are doing surgery, there is a perforation, puncture, and it becomes difficult. So it will be better if you inject trypan blue and then do the dissection. Some people just draw the fluid and make the thing easier. Or you can do, if it is a more often solid type, then you can just excise it, meticulous excision. These are some other type of cysts. These are cystic looking lesion. This is an cystosarcosis. This patient presented to us with this inflamed, and the next day she came back with this type of picture. This is a pseudophacosil. You can see sometimes it is difficult to identify this type of the lesion or what is their type of cyst is there. Coming to the melanocytic lesion, there's very interesting names are there, CAM, PAM, and SAM. CAM is complexion associated melanosis, increased number of melanin, not the increased number of melanocytes. They are bilateral. They're also called racial melanosis. As you can see in the both eye, it looks like a papery appearance. The primary acquired melanosis, this is papery appearance, and this one is actually cobblestone appearance, this CAM. And this primary acquired melanosis, there is also increase in the pigmentation, but these are papery, these are unilateral. Unlike the CAM, this is unilateral. Pigmentation, if more than 1 to 2 clock hour, then you have to go for excision, wide excision with the surrounding, taking clear zone. This is a more aggressive form. There are 2 types of PAM. One is, these are histologically, you have to find out what type of PAM, whether PAM with atypia, PAM without atypia. If it is a with atypia, then you have to do to take it as that there is a chance of melanoma. This is the other eye. So other eye of the patient is absolutely normal, only one eye. Secondary acquired melanosis, in case of inflamed eye after conjunctivitis, allergic conjunctivitis. Many times you'll see after vernal conjunctivitis, this type of picture. This is secondary acquired. This picture I took from Google Images just to show that this increased number of the melanin within the epithelial cell. They have not crossed this basement membrane. But in case of PAM with atypia, they have crossed this, and there is the feature of the melanocytes are also various types. That is, there is atypia, increase with melanocytes. This is another rare thing, nevus aorta, oculodermal melanocytosis. They are actually not in the conjunctiva. They are in the episclera and the sclera. They may be seen and they are usually congenital. Black races are involved most. This is the 1-year boy who came with this type of picture. It's another lady of 45 years old. You can see the whole of the first and the second division of the trigeminal nerve is affected, flat blue or black pigmentation. Usually occurs in dark complexion, more in female. 2/3 have the black patches on the sclera and the uvea also. As you can see in these cases, you just the auditory external auditory meatus, you can see in the hard palate. The important thing is that you have to keep in mind this should be follow-up. 10% can have chance of glaucoma, uveal melanoma 0.25% of the cases. So this is important to do follow-up in this type of cases. Coming to the conjunctival tumor, they constitute 35% of the periocular tumor. 30% of the conjunctival tumor are malignant. The very common thing is the nevus. Look at the nevus. Typically they are pigmented lesion at the limbus, well-defined margin. There may be some inconspicuous 1 or 2 blood vessels also may be situated at the limbus or at the canthal region or at the fornix. So these are, the thing is that they are present since but sometimes they become arid when it increases in puberty and pregnancy, slightly raised, well-defined. That time they usually visit to us. You have to can do this UBM, ultrasound biomicroscopy, to see the internal structure. As in this case, you can see there's multiple cysts are there. Even clinically, if you carefully observe the slit lamp examination, the multiple cysts are there. Once the cysts are there, you are quite relaxed. You know that this is not an malignant condition. This is a benign condition. You just do follow-up. This was a bit suspicious look and cosmetically disfiguring also. I did this excision with amniotic membrane transplant. As I told, malignancy is rare, 1%, so follow-up should be done at an interval of 6 to 12 months. This is another case of nevus. When the boy of 9 years came to us, I was a bit worried what we are dealing with. The lesion presents since birth, but there is an increase last 6 months. But if you examine the slit lamp, you see that this is the rest of the globe is actually there is no feeding vessels. Only here there is 1 or 2 very small vessels. Otherwise, the UBM also you can see the cystic structure. But as it is a very large site, there was a small lesion at the caruncle also. So surgery was done, and along with this amniotic membrane transplant, and then put the conformer. This was the post-op picture. Some amount of, we had to do a second surgery because there was some pigment was there. It was actually a balloon cell nevus, which was diagnosed by histopath. Coming to the most interesting and the most common lesion of the that is the ocular surface squamous neoplasia. This is the 3rd most common ocular tumor after melanoma and lymphoma. Incidence is between 0.13 to 1.9 to 1 lakh. High incidence in the people who live close to the equator because the ultraviolet ray, they causes damage of these limbal stem cells. So OSSN is an umbrella term. Look at this picture. This is the conjunctival intraepithelial neoplasia, dysplasia, and the squamous cell carcinoma, all under the same term, the OSSN. According to severity, it can be pseudoepitheliomatous hyperplasia, it can be Diskeratosis, benign hereditary intraepithelial diskeratosis papilloma, pre-invasive OSSN, invasive OSSN. Risk factor, as I told you, radiation, male gender, smoking, chronic trauma, exposure to petroleum products, old age. Average age is 60 years, but it can occur between 20 to 70 years age group. These are the some of the conditions which may be associated xeroderma pigmentosa. If it occurs in the young because of the xeroderma pigmentosa and the HPV, then it is in young patient. Some picture of xeroderma pigmentosa. There's various types of the conjunctival lesions. You can see starting from diskeratosis, intraepithelial neoplasia, even squamous cell carcinoma can be seen in these cases. The morbidities are very high. They have got some other systemic defect also. Coming to the classification, look at these are various morphological classification. The gelatinous variety, the mucoepidermoid variety is a very aggressive form of the OSSN. This is the nodulo-ulcerative variety. Sometimes this is misdiagnosed. In my case, at least I misdiagnosed once upon a time. I was bowled out by this case. I thought it is a case of necrotizing scleritis. But the presence of this keratin is actually the identification feature or diagnostic feature. These are vascular and the presence of the keratin. Coming to this lesion, OSSN sometimes may be a pigmented lesion, a gelatinous lesion, sometimes with a very, very vascular. This is not gelatinous, this is an actually leukoplakic lesion. Papilliform lesion, these are various types of lesion. Diagnosis depends on if you see, and this is invariably, this is at the interpalpebral location. Invariably, it will involve the limbal area because the stroma is the culprit. If you draw a line perpendicular at the stroma, you will see the epicenter is always at the stroma. Half of the thing will be inside and the rest is outside. The epicenter, remember the epicenter will be always at the limbus. And the keratin and the vasculature. The vasculature is more prominent. Sometimes it may be pigmented, as I told. Rose Bengal staining is a good thing if you are to identify the how much area is involved before going to the surgery, or if you are in a dilemma whether it is actual, then you see, look at this, there is thickened hyper-ASOCT, thickened hyper-reflective epithelium with an abrupt transition area here in the cornea. And the keratin has produced some shadowing underneath. Impression cytology is not done much in our center because they fail to differentiate between dysplasia and the squamous cell carcinoma. Coming to a bit of surgery, this is a surgery, how you have to take care. Accurate diagnosis before the surgical intervention is very much needed. Wide excision, cryotherapy, lamellar sclerectomy, plaque brachytherapy if it is a deeper lesion, intraocular invasion if it is there, then you have to go for enucleation. If there is intraorbital extension, then you have to go for exenteration. And sometimes you can start with if you are very, very sure that you are dealing with a case of OSSN, it's a very small size, you can start directly primary therapy with the neoadjuvant therapy. I'm coming to that later. And or sometimes you have done the surgery, now you can add it with the adjuvant therapy by the this chemotherapeutic agent or immunotherapy. This is double phase cryotherapy and the cut area of the conjunctiva. This is very important. Then I'm not, just for the sake of giving the amniotic membrane transplant, just put 4 sutures at the end, and then you put finally the contact lens. Coming to the topical non-surgical management, as I told, you can do mitomycin C 0.0 to 4% topical 4 times a day, 2 to 4 weeks. This is actually many centers, they do it differently, like 1 week and then 3 weeks gap like this. Mitomycin is actually what we have found that it is not a very good drug because of the side effects like more of ocular toxicity. 5-fluorouracil 5-FU 1 to 2% is a better drug. This was the patient we treated with the 5-FU, and this was the result at follow-up at 2 weeks. Interferon, this is a very good drug, but this actually takes some time. It can be used for immunotherapy or in reduction to reduce the immunoreduction, decrease the size of a bigger size lesion, or immunomodulation you can do, or topical eye drops you can use, or you would do an injection in the perilesional, or some people give it in the intralesional area. This is a patient which we treated, recurrent case of the pigmented OSSN, and then finally we followed it with the injection and the topical medication of the interferon alpha 2b. This is a very good drug. Prognosis, overall prognosis is good. Metastasis mainly which occur is the regional lymph node. Rarely it can go to the, if it is a squamous cell carcinoma, it can go to the intracranial. Recurrence risk up to 39% after treatment is reported. So follow-up is important. 6 months after resection, you have to follow. Recurrence depends on the involvement of the surgical margin, whether you have done it 4 millimeter, you have taken tumor-free zone, or that is HIV infection status, histopathological grading, availability of adjuncting therapy, immunotherapy, chemotherapy, what you have used. Recurrent OSSN can grow rapidly. You have to be cautious to treat those cases. Differential diagnosis is very important. You have to differentiate actinic keratosis. For the sake of time, I can't go to the detail. This inflamed pinguicula, sometimes maybe a differential diagnosis, pseudoepitheliomatous hyperplasia, pyogenic granuloma, conjunctival tarsal cyst, squamous cell carcinoma. These are 2 cases I got in an advanced squamous cell carcinoma. This we had to go for exenteration finally. As you can see, after the exenteration, the patient was rehabilitated like this. And in this case also, these are the cases who come very late in a tertiary care center. This is conjunctival melanoma. This is a melanocytic tumor where there is a number of as I told, this can occur from a primary acquired melanocyte cytosis in 60 to 70%, de novo in 10%, nevi in 20% of the cases. So nevi also you have to do follow-up. This is a raised, it may be pigmented, sometimes it may be non-pigmented. That is more difficult to diagnose. Adults 60 to 70 years, UBM, ASOCT or UBM was done to find out whether there is intraocular penetration. So finally, this case actually there was a recurrence after excision, so we had to go for enucleation. This is another case. Look at the vessels, tortuous vessels. I'm trying to just depends on the tumor thickness. The treatment protocol is almost same as the OSSN, but they can spray it to the other structures of the body like lungs, liver, all those things you have to check. Conjunctival lymphoma is a very common tumor, actually 1.5% of the conjunctival tumor. Look at this salmon pink color of the lesion. They may be in the bulbar conjunctiva or in the fornicell conjunctiva. They may be associated with the lacrimal gland involvement also. Multifocal, 50% is unilateral. And they are, many times actually, they are associated with systemic lymphoma. In case of bilateral, these are associated usually with the systemic lymphoma. Look at, they can come with a mechanical ptosis also. In case this was the case who came. The CT and or MRI is very important. Look at this CT picture and the MRI. They actually mold with the lesion molds with, this is the characteristic feature of this lymphoma. They mold with the periocular area. So this is easier to diagnose by seeing this. But final diagnosis will definitely depends on the biopsy because it is a lymphoproliferative disorders. It is a wide spectrum of disorder. It mostly they are MALT, mucosa-associated lymphoid tissue. The lymphocytes and the T lymphocyte, B lymphocyte, which are seen in the adenoid layer of the conjunctiva, they are. Sometimes you may have to differentiate it with nodular scleritis, episcleritis, amyloidosis. Coming to the treatment, the staging, I'm not going to the detail of the staging. There is various stagings are there. These are AJCCTNM classification. Before starting the treatment, we have to go for the staging. Whether you will, if it is a very small lesion, you can do cryotherapy, or you can see the extent, you can do the excision or systemic. If it is involvement of the lacrimal gland, if it's a large lesion, a systemic lymphoma is there, then you have to go. Chemotherapy or immunotherapy may be also done in some cases. If
Ma'am, I request you to please quickly wrap it up.
I think, how much time I have left?
Ma'am, it is already overshooted. We have 30 minutes for other
This is not my
presentations.
picture, Kaposi sarcoma, just to have a look, just what it can be. Amyloidosis, these are also, you have to see like ptosis. If there is a ptosis in the upper lid, just invert the lid and you can see this primary amyloidosis of the conjunctiva, or it can be secondary also. The excision was done. After 2 years, the patient developed it in the other eye also. These are some conjunctival amyloidosis, which could be primary or secondary. These are, I am just trying to wrap up. These are, sometimes the patient can come with, it is very important, the bilateral amyloidosis came with a subconjunctival hemorrhage. Then diagnosis become difficult. Remember that you have to, in investigation, you have to rule out leukemia, lymphoma, multiple myeloma, metastatic carcinoma. You can treat the patient with surgical excision, cryotherapy, debulking of the lesion. Complete lesion removal is difficult. To work up, thorough history taking is very in the old age is a very important thing for the malignancy. Remember, sun exposure and old age, xeroderma pigmentosa, the fleshy lesion, pyogenic granuloma. This is, you've heard the lead. Regional lymph node, you have to palpate. History, cigarette smoking, sun exposure, all these things. Patient is HIV infection, family history of any lesion in the NHL, cutaneous melanoma the patient has got, post-organ transplantation, all these things you have to, then draw a diagram, what you are saying, and do follow-up and see what changing is there. You draw it in your workup, and sometimes you may have to discuss with your friends, what the colleagues, to come to the diagnosis. All these investigations, not to be done in the same case, but remember they may be needed. These are case specific, what you are going to do. CT or ASOCT or MRI or UBM, what is needed, depending on your clinical diagnosis, you have to proceed. There are some spotters. This is the Bitot spot, the bilateral fat prolapse, this is unilateral fat prolapse, this is dermolipoma, this is a flectenular conjunctivitis, the pigment OSSN. This is the case of sebaceous gland carcinoma pagetoid form. Look at the unilateral conjunctivitis. This is a solid chemosis. It's after Calazian operation, this has occurred. This is a staining. Some patient can come with a staining of the Schurma staining. So you have to remember at the conclusion, I want to say that in every case of ocular surface abnormality, if you see something atypical, then you have to do a close follow-up and come to the diagnosis and appropriate investigations. Not all cases need intervention. Sometimes some benign cases, you can just keep it like that and do follow-up. These are my postgraduate students in different medical colleges. I acknowledge my unit. Thank you for your patience hearing.
Thank you so much, ma'am. I would like to take Sharmila ma'am's input on this presentation.
That was an amazing presentation, ma'am, with so many clinical scenarios. I think your final slide just summed it up with all the different varied types of presentations. Yeah, as you rightly pointed out, like sometimes an ectodermal scleritis, you might think it is an ectodermal scleritis and it can be a malignant lesion. So many times a pigmented amelanotic melanoma or sebaceous gland carcinoma presenting as a unilateral chronic conjunctivitis, or even a pigmented OSSN can be mistaken for a melanoma. So it's very important to see all these different features. Each one has a signature, and it's important to see all of it. And just want to stress again that importance of anterior segmentosity just caused a paradigm shift. Madam covered everything extensively. Thank you so much.
Thank you, Dr. Sharmila.
Absolutely. Thank you so much, ma'am. We are running short of time. I would like to invite our
Sorry for
next
the extra
speaker.
time. I'm really sorry.
I would like to invite our next speaker, Dr. Madhuri Parande, ma'am. She is going to speak on the recent advances in the surgical management of pterygium. Over to you, ma'am.
Yeah. Is my screen visible?
Yes, ma'am. Can you make it full
Am I
screen?
audible? Yeah.
Yes, ma'am.
It's fine.
No, it's not on full screen.
It's
Yes,
not.
right. Yes, now it is.
Now is it?
Yes, ma'am.
Yeah. At the outset, I want to thank the AIOS, the GuruSangam team, Dr. Santosh Navar and Dr. Manoj Mathur for this opportunity. Today's topic for me is surgical management of pterygium, the recent advances. I have no financial disclosures to make. So this will be our learning objectives, brief clinical anatomy, which is actually dealt by with the previous speakers, clinical presentation, pterygium, epidemiology and pathogenesis, medical management, various methods of surgical management, and the recent advances. Pterygium, as we know, is derived from the Greek words pteryx meaning wing, pterygion meaning fin, and it's known as a pterygium. It's a triangular fibrovascular subepithelial overgrowth of the degenerative bulbar conjunctival tissue over the limbus onto the cornea. As you can see in this clinical photograph, it has three parts. The red one is the head, that is the apical part which overgrows on the cornea. The narrow part which is on the limbus, it's not called the neck.
Ma'am,
And
sorry to interrupt. There is this
yeah,
gray box which is coming over the pictures.
over the picture.
Yes, can you reshare?
Yeah, okay. How is it now?
Still there are gray box, yes.
But I can see it clearly here.
Okay.
Shall I do it again?
I think you can continue.
But all my pictures are on the right side.
Okay.
Doctor, can you do me a favor? Can you stop for a share for a minute?
Yeah.
Just click on share button once. Don't go sharing.
Okay.
And on right side, you will have an option called optimize for videos. Just uncheck that box.
It's unchecked. Optimized for video sharing, right?
Yes.
Yeah, that's unchecked.
And just try again, or just click and unclick. Just check and uncheck. Just for contingency's sake, just check the box and uncheck,
Yeah,
and
I did
then
it.
go sharing.
I have done that.
Now
Shall I
you
share
can
it
share.
again now?
Yeah, please.
No. So
It
now
is
I
still
can.
there. It is
Yeah.
still
Now
there.
I can
Just-
see. I can see when I share that there is a gray box, but I can't. I don't have it in my screen now.
Okay, on the video which is there on the right hand side, you have a minus. Just click on it. It should get minimized, or you can drag it to the bottom.
One sec.
The right hand side box, you will have a minus sign, right? On top right hand side.
Yeah,
You
the
can
more
minimize.
thing.
You can minimize this and continue, or you can just click and drag to right and
Acha,
right.
here, this I'll minimize.
You can minimize, or you can drag to the bottom of the screen and continue. It should do
One
the.
second.
Yes, you can just drag and yes, perfect. We can continue with this.
Is it seen now?
Yes, all good,
Yes,
doctor.
ma'am.
All good? Yeah. Okay. So I was talking about the parts of the pterygium. We have three parts of the pterygium, the head being the one, the apical part, which is on the cornea, and the neck being the constricted part on the limbal side. And the body is the scleral part, which is from the limbus to the canthal area. And there's sometimes a semilunar whitish infiltrate at the ahead of the head part, that is apical part called the cap. And as mentioned by the previous speakers, there is something called a stalker line, which is a linear epithelial iron deposition, which occurs due to tear film abnormality. And also there are something known as Fuchs islets, which are small, discrete whitish flakes, which are present at the apical part sometimes. As we have conventionally read that there are three types based on the sizes of the pterygium. If it's less than 2 millimeters, we call it type 1. If it's 2 to 4 millimeters, we call it type 2. And more than 4 millimeters is grade 3, which can also involve the visual axis. It can also be divided into progressive and regressive pterygiums. That is, the progressive pterygiums are thick, they are fleshy, vascular, and also have the cap in front of the apex. The regressive pterygiums are thin, atrophic, with very little vascularity, no cap, and sometimes the stalker's line. So, coming to the understanding of the disease, we have known that the prevalence rates are different in various parts of the world. It is highest in the pterygium belt, which is described by Cameroon, which lies 37 degrees north and south of the equator. So in the world, the prevalence rate is about 0.3 to 29%. In India, it is about 9 to 13%. It's more in rural areas in males and with increases with increasing age. We also know that it is a more nasal preponderance. The causes for this is that the light passes through the cornea medially and it reflects from the nose and concentrates on the nasal region. And the longer temporal upper eyelids and bowing filters the temporal light. The natural flow of tears from temporal to nasal side will cause the toxin accumulation to be more on the nasal side. There is another hypothesis that there are two anterior ciliary arteries on the nasal sides while there is one on the temporal. So any irritant may cause increased nasal hyperemia. We've had a history of hypothesis from syndrome of wind, heat, damp heat in the early years to being it hereditary and then coming to ultraviolet light being the main cause for causation of pterygium, which led to multiple inflammatory responses, immunological mechanisms and oxidative damage. There was also a viral mechanism which was proposed. Now we have come to many things like oncogenic proteins, P53 mutations. Then we have limbal stem cell deficiency, which was proposed, and now leading to many biomarkers which are altered in causing the pterygium. So UV exposure is acting as an insult, causing much extreme cellular damage in various modes. That is, it will disrupt the biochemical pathways in matrix metalloproteinase mechanisms. It will cause DNA damage indirectly or directly. Then it will affect the P53 pathway, causing apoptosis mechanisms. Then affect the nuclear repair mechanisms, leading to dysplasia, leading to pterygium. This is the things which we have known, right? Like UV exposure, exposure to dust, limbal stem cell deficiency, and viral infections can have a predisposing factor. Now there are many mechanisms which are proposed due to UV light. That is, there is increased production of certain biomarkers like VEGF-A, which leads to multiple molecular pathways leading to increased nitric oxide levels. Or there are multiple sea of biomarkers which are found out and which with different categories which are seen that they are deranged in the pterygium tissue and the surrounding conjunctival tissue. If in this C, it can be divided into certain things which are upregulated like the matrix metalloproteinases, the MDM2, and downregulated like the E-cadherin, LATS1 and LATS2 and P53. So there is this review article which states that there are critical roles that the biomarkers play in severity, recurrence risk prediction, and adjuvant therapy in pterygium. It emphasizes that the P53, which is involved in pterygium by abnormal changes in various pathways, will have different phenotypes and different developmental stages. Because of this, it can have potential targets for therapy. Um, Also, there is upregulation of TGF beta 1 and multiple interleukins, which can have a effective role in which can play an effective role in pathogenesis of pterygium. I want to stress the P53 MDM2 interaction. As we know that P53 is tumor suppressor gene, and mouse double minute 2 is a protein which is a negative regulator of P53. It will inhibit the translational activity and it will stimulate its degradation. So when there is overexpression of MDM2, it will inhibit P53 and favor uncontrolled cell proliferation. So this interaction and this pathway is a potential target for usage in terms of therapy. There is something known as a Nuclein 3A, which is an MDM2 antagonist, which is studied as a potential therapy for, it can have, like in future, it can have a therapy which can reduce the MDM2 so that the tumor suppressor decreases and cell proliferation decreases. So we know that the histopathology, it's a fibrovascular connective tissue that migrates from the conjunctiva to the cornea. And basically there is a collagen mixed with basophilic fibrillar structures and vascular changes. The epithelium, as we have always known that most of the times the epithelium might be normal and the main pathology is in the subepithelial lesions. The epithelium can just show sometimes an acanthosis or an atrophy. There is a study which by Serra et al. Which says that there are four types of conjunctiva which can be found in pterygium. So it can be a normal pterygium with normal epithelium and stroma. Then it can be a fibrous pterygium, that is a fibrous band which you can see under the epithelium with the solar elastosis in the stromal lesion. And the third picture shows you an angiomatous pterygium. That is, there is an increased number of epithelial layers, and with increased number of vasculature in the stroma. And the last is the mixed pterygium, which will have both features. The TANS grading is what we've always known. That is, it is divided into T1, T2, and T3. That is, a T1 is an atrophic pterygium with episcleral vessels underlying the body of the pterygiums are obscured and clearly distinguished. Second one is the intermediate type, where it is not distinctly seen and partially obscured. Third is the fleshy type, where the episcleral vessels are totally obscured. This is how we used to grade the pterygium earlier. So there is another grading system, including this. What we can use is, it is proposed by Liu et al. That we have to take care about the area of the pterygium as well. Sometimes what happens when we say that there is just a 2 millimeter encroachment onto the cornea, actually the encroachment is 2 millimeter, but the area is very broad. So the area is not taken care of when we kind of grade it in by 2 and 4 millimeters. So this will take care that the area is also taken care and the severity is also measured in terms of the area. So coming to management of pterygium, um, so when the pterygium patients can present either asymptomatically or symptomatically. When they are asymptomatic, we can just document and prescribe lubricants so that they have some amount of relief in case. And in symptomatic patients, we have to grade the pterygium. And if it's a grade 1 atrophic pterygium with no impact of vision or no other cosmetic challenges, then we can still document and give a medical management and postpone the surgery. In grade 2 and 3, where there is a impact on the vision and there is a cosmetic challenge, then we can pre-treat with steroids and reduce some amount of inflammation and vascularity and then plan surgical excision. Any keratinization of pigmentary changes can be taken up for surgery and sent for histopathology. So I'll be shifting to surgical techniques. So when we talk about surgical management of pterygium, we have multiple options like excision with a bare sclera, excision with a primary closure, excision with an amniotic membrane graft. Then we have a conjunctival graft. The conjunctival graft can be an autograft, it can be a conjunctival limbal autograft, a rotational autograft, or a in situ autograft as well. So it all started off with D. O'Brien in 1948 proposing the bare sclera technique where the head and body of the pterygium are excised and left to heal on itself. This procedure had about 25 to 90% of recurrence. Now what there is the change is that if the people do bare sclera with mitomycin C, then the recurrence is reported is less, but it is not as equal to other standard methods of pterygium excision. You can also do a primary closure, that is the head and the body of the pterygium, everything is excised and the conjunctival approximation is done. Here it can be just approximated as it is or a rotational flap can be used. This process has a high recurrence of 35 to 40%. Then came in Kenyon et al. Proposed the conjunctival autograft method, which is currently the standard treatment procedure. It's also the gold standard because it has the least recurrences of the PROS procedures. So here what we do is that we excise the head and neck at the limbus and the body of the conjunctiva and like cut a small strip of the pterygium. Then we harvest a superior conjunctival graft and it can be either sutured to the base sclera bed or attached there with the fibrin glue or an autoblood. See, as you can see in this video, I've already excised the pterygium from the cornea. Now you can see that all the leftovers which are there on the cornea should be smoothened for it to heal nicely. Now I'm harvesting the superior conjunctival graft. This is the area where the conjunctival graft is harvested. Before the conjunctival graft is harvested, we can give a subconjunctival injection of lignocaine to form a small bleb. Yeah. So we should try for a tenons-free graft, and the conjunctiva is excised and placed on the bare scleral bed. So this is the excision of the conjunctiva. I'm making sure I leave a small 1 mm rim at the limbus for the conjunctiva in the superior part to heal. So this is placed on the bare scleral bed. The procedure I'm using here is with an auto blood. I'll talk about it in a few slides later. Okay. So other than the graft being there, we can also use something known as an amniotic membrane graft. It has a lot of anti-inflammatory properties. It will facilitate reepithelialization and minimize fibroblast proliferation. Is it easily available? But many studies have shown that it has similar recurrence rates with conjunctival autograft. But in my experience and my hands, it has not worked very well. Another thing is conjunctival limbal autograft. This has the same procedure as the conjunctival autograft. The only thing is that what we do is we take a small 0.5 mm of limbal tissue, as you can see in this superior picture on the screen graph, and place it on the bare sclera. It has better anatomical and functional result. It will also restore the limbal barrier. The recurrence rate is about 2 to 5% as reported by multiple studies and RCTs which are done to compare limbal conjunctival autograft with just autograft, or there are many assays to compare conjunctival autograft with or without mitomycin C. They have found that 2 to 5% of recurrence is present in this procedure. The only thing is it has an increased surgical time, and in case you harvest a very large graft, then you can cause an iatrogenic limbal stem cell deficiency. And also you can harvest too much of conjunctiva, and in case the patient needs a glaucoma surgery later on, then there can be failure of the bleb. So in this video, if you can see that I'll go through the video. Sorry for the non-centration. Another thing I want to emphasize is that after removing the head of the pterygium, we have to always remove a strip of the pterygium which is there at the conjunctival side. That will decrease the thickness of the opposition between the graft and the host junction, and also it will prevent the overlap of the host junction with the graft. It will help in easy healing of the graft. Okay, as you can see here, I have taken a superior conjunctival graft. Okay, so there is a little bit of dissection which goes into the limbal area, including the palisades of Vogt, to harvest some amount of limbal cells, and then rest of the procedure is almost same. Okay, then another procedure which is proposed by Lawrence Hurst from Australia. It's known as the perfect procedure, that is pterygium extended removal followed by extended conjunctival transplant. What he proposes is to remove the pterygium extensively until the medial canthus, including the semilunar fold, and replacing it with a very large graft onto the nasal side. It's very time consuming procedure, but he claims a zero recurrence with it. The Cornelius modification of this procedure has had less complications, which Hurst had in his series, but the recurrence rate he reported was about 1.6%. Then another procedure called pterygium extended removal followed by amniotic membrane transplant. So Liu et al. Proposed that the same procedure with extended removal and can be followed by amniotic membrane transplant other than the conjunctival graft, but it had many complications like postoperative granuloma, transient diplopia, motility restrictions, and early detachment of the amniotic membrane, leading to a recurrence rate of 6.89%. Now, there is also a discussion on whether we should take a graft or a flap. Multiple studies have concluded that the results are comparable but are very variable. Rotational flaps can have a recurrence around 2 to 8%, and not only superior rotational flaps have been tried, inferior flaps have been tried as well, and they are claiming to have similar recurrence rate in inferior conjunctival rotational flap as well. Then another new procedure known as mini slit. That is, as we know that the limbal barrier is broken in case of pterygium, um, what we do here is to remove the pterygium and rescue the limbus by a limbal epithelial transplant. It's a mini because we take a smaller 1 mm of the tissue from superior conjunctiva, superior limbus, and it is broken into small pieces as you can see in this picture. It is placed near the limbus with a fibrin glue, and an amniotic membrane is placed on it and fixed, so that the small bits of the limbal tissue can grow and then form a limbal barrier, and it will avoid the avoid the conjunctiva to be sacrificed from the superior side. This was a mini slit. Now you can do a full slit as well. That is, a limbal strip of about 4 into 2 mm is taken, and then with the same procedure, it is spread over the limbus and with amniotic membrane and BCL. This can be very useful in case of a double-headed pterygium where you want to even restore the ocular surface reconstruction can be done, and you don't have enough amount of conjunctiva to be, which will be enough to suffice for both sided bare scleras. So recently there was another paper called Permislet, that is a pterygium extended removal followed by a mini slit. So here what they are doing is they're doing an extended removal as of the perfect surgery and doing a slit of a mini slit. So you do an extensive tenous tissue removal with a large cord area and do a mini slit with a amniotic membrane graft. So they have reported a zero recurrence at 12 months, but the drawback of this study was there was a very small group, that is only 9 patients were studied. Especially these things can be, this was done in a recurrent pterygium, so it can be helpful where you can't harvest graft again and again. Okay, so there are certain suture-free alternatives. What we can do is autologous blood or what is known as a sutureless or glueless alternative. It's a excellent alternative to fibrin glue. You can see in this picture that there is a excellent post-operative comfort compared to sutures. But there's also a issue of graft retraction, sometimes with graft dehiscence or loss, and graft edema. In the above picture, you can see that this is a patient who had a bilateral pterygium. The left eye is already done and healed. It's then the right eye has been done and there is a graft in situ with a small seroma under the graft. Even though the graft is quite well opposed, in the immediate post-op there can have some redness. The graft can have be edematous and yellow, but after a while it settles down. Like this is a fourth week picture of the same patient, and both eyes are looking great. So this is the same video. I'm just showing how do you put the graft with an auto blood. See, now as you have taken the graft from the superior side, what we try to do is when there is a bare sclera there, try to pinch or prick small vessels so that we induce fresh bleeding. After that is done, the graft is slided over the area. There is another thing called bot graft. The Botoclode solution, which contains hemocoagulase, it claims that they can have a gradual fibrin network which allows for meticulous graft positioning and adjustment before final adhesion. It is very cost effective as it's 90% cheaper than fibrin glue. In resource limited settings, it can be helpful, but larger comparative studies are needed to confirm whether there is less recurrence in this graft as well. So now coming to the adjuvants, radiotherapy was one of the earlier adjuvants which was used. It was high energy beta emission radiation, which suppresses the fibroblast proliferation. Ruthenium 106 and strontium 90 was used, and they had a recurrence rate of 0 to 50%, which was very variable. But there were serious complications like cataract, scleral necrosis, corneal perforation, and endophthalmitis. Now we have other things like mitomycin C, 5-fluorouracil, cyclosporin, and anti-VEGFs. The fibrin glue, which is used very extensively nowadays, is a biological and a biodegradable. Fibrinogen and thrombin, they form a adhesive network and they stimulate the last steps of the clotting mechanism. Multiple kits are available. Like in the pictures, you can see the one with Baxter, like a T-Seal kit. There's a Relisil kit from Reliance and a Fibrosil kit. The TCL is a little expensive one, where the other two are cost effective. The fibrin glue has a decreased surgical time and better post-op comfort and reduced recurrence. It also has a better cost basis compared to autologous blood. That is, it will give you a white eye on post day one, whereas autologous blood will doesn't do that. Coming to mitomycin C, which is an antibiotic and an antineoplastic agent, it was first isolated from bacterium Streptomyces caspitosis. It undergoes reductive activation to become a potential alkylating agent. Under hypoxic condition, it will interfere with the DNA replication by cross-linking DNA. So it is effective in cells which are actively dividing. So this is very well used nowadays in the range of 0.01% to 0.04% intraoperatively. What we do is a generally 0.02% of mitomycin C. You can see a screen grab. We keep a few pellets under the conjunctiva, and for 1 to 3 minutes, depending on the severity of the pterygium, and always remove the correct number of pellets, and wash thoroughly with about 20-25 ml saline, and avoid keeping it on the epithelium, corneal epithelium, which can lead to, and also for a longer time, which can lead to scleral necrosis and also can cause epithelial toxicity if kept on the corneal epithelium. Using a mitomycin C as an adjuvant to the conjunctival autograft or limbal autograft or with an auto blood can act as a very helpful adjuvant to prevent recurrence of the pterygium. It will also reduce the vascularity and the thickness of the pterygium when used preoperatively. Cyclosporin is another antimetabolite. It blocks the expressions of MMP3 and downregulates the myofibroblast markers. It will also decrease the fibroblast migration and angiogenesis. Many studies have reported a recurrence of 2 to 20% depending on the sample size. Earlier, the cyclosporin was available in 0.05% eye drops. Now there is another percentage, that is 0.09%, which is also available in ULIPs. And this is a higher percentage of cyclosporin, which can help, which can get good results. But we don't have a long-term study as yet to confirm that. It will also help in patients who have coexisting dry eye. 5-fluorouracil is a pyrimidine analog and it will cause apoptosis of the fibroblast. It can be used as a primary treatment or as an adjuvant post-op. As it's very well used in the glaucoma in the sense trap surgeries as well. It has a good range of safety. We can take a 0.1 ml of 5-FU in 1 ml syringe, and it can be given intralesional under topical anesthesia weekly within 1 month from the date of recurrence if you do it post-op. 3 to 5 injections should decrease the vascularity and thickness in about 90% of the patients. Next, coming to anti-VEGFs. As we saw in the ectopathogenesis that the UV radiation can increase the growth factors which can lead to cell proliferation. Anti-VEGFs like bevacizumab are also being used intralesionally, that is about 2.5 mg in 0.1 ml, and they have given comparable results with the other antimetabolites. But the only disadvantage is that there is a poor stability and a decreased shelf life, and it's expensive compared to the other antimetabolites. So coming to certain new things which are tried in pterygium surgery, there is something known as collagen implants. Like the ones used in glaucoma surgeries are also used, can also be tried as an adjuvant, and they are placed on the, the bare sclera, and over that there is a amniotic membrane placed, and collagen implants, matrix implants are also tried, but there are no long-term studies for that. Few investigations which can be helpful and are used nowadays are anterior segment OCT. So what is the advantage of seeing doing an anterior segment OCT is that the actual size and the depth, the penetration can also be visualized in ASOCT, and it can also be quantified. As I said that the area of the pterygium can also be visualized by taking anterior segment photographs and marking the width and length of the pterygium. Here the apex limbal distance, the width and the area, everything can be quantified and documented. They've also found in this study by Marina et al. That there is something known as a hyperreflective epithelial edge, which can guide us in excision of the pterygium, and also a subpterygial space which is seen in the ASOCT, which can help us to predict risk factors for recurrence. They also said that a graft which is less than 3 mm can have an increased recurrence rate. So using antersegment OCT in future can have us quantify certain things so that we can predict recurrence for the depending on the severity of the disease preoperatively. Femtosecond is also used nowadays for pterygium surgery. It is known as femtosecond laser assisted pterygium surgery. Fused et al. Presented this article where they used the preset trapediology so that a perfect size and shape and depth of the conjunctival graft can be dissected using a femtosecond laser, and so that we don't harvest more graft and sacrifice more conjunctiva. Next is anterior segment fluorescent angiography. This was performed as a pilot study in 5 patients. Noha et al. Presented this paper. They were finding out the healing of autologous conjunctival grafts in a pterygium surgery. It's a very good paper to read. They have documented stage by stage how the graft actually heals and how the vessels take up uh, on anter-segment photography, as well as they have done an anter-segment fluorescent angiography to know where, yeah, if you can see in the third picture, you can see that the horizontal long linear vessels are all taken up, and it heals quite well. Robotic assisted surgery is also present. Boshier has presented this paper on a first human case doing a pterygium surgery with a conjunctival autograft. I think robots can come everywhere. Okay. So concluding my talk for residents, you can get questions like recent advances in pterygium management, recent advances in surgical management of pterygium, or uses of mitomycin C or metabolites. Generally, what residents do is they just write one or the other procedure, thinking that is the recent advance. So what you can do is you can divide your answer, or tabulate your answer on subheadings like the etiopathogenesis, diagnosis, grading, medical managements, and surgical techniques. And you can talk about each thing and what's new in each thing so that you can get few extra marks. I thank my alumni, Karnataka Institute of Medical Sciences, Hubli, and my workplace, Mysore Medical College and Research Institute, Mysore, and also to the AIOS GuruSangam team for this opportunity. Thank you.
Thank you so much, ma'am, for beautifully describing all the recent advances. I'm amazed to know that even femtosecond and robots can, be used in managing pterygium. So we have come a long way when it comes to pterygium management.
Yeah.
So may I request Dr. Tuhin Chaudhary, sir, for his inputs?
Thing is that actually nicely covered everything. Just one thing I want to highlight that there is no role of amniotic membrane transplantation. Basically, if you it is a recurrent pterygium also, if you put it, there will be again recurrence. So people may feel to go for amniotic membrane transplantation. It is as just will be just fitted only as a last resort where you cannot get any or you cannot harvest any congenital autograft. And there is another thing that people should avoid conjunctival autograft. So if you take this limbus, even for recurrent pterygium also, then there is chance of no extra advantage, and you are just damaging the limbus from the donor side, and that lead to again there is some sort of this atherogenic limbal stem cell deficiency at the donor side. So congenital limbal autograft or the amniotic membrane transplantation should not be done. If it is required, only congenital autograft is most important.
Thank you, sir. May I request Archana ma'am for her comments?
Am I audible? Yeah.
Yes, ma'am.
So yeah, this was a great talk, and ma'am has covered everything, like right from the anatomy of the pterygium until the femtosecond and the robo. So this is an amazing and a great talk, and it is really nice to know about the role of femtosecond in the management of pterygium.
Yes, ma'am. Any other comments from any speakers or panelists?
I wanted to ask Tuhin sir, like, what is your take on free conjunctival graft, sir? Not on not as you said, you can avoid the limbus as well.
Pre-congenital graft, Basically, free conjunctival
Also
graft,
works, right?
limbal autograft, whatever you take, but there is no point of giving extra advantage of limbus. So I should destroy that limbus from the donor area.
Mm.
And second thing, that if you feel that
Mm.
if you want to, if it is a very large pterygium where you have gone for this perfect technique in recurrent pterygium, so you can put this conjunctival strip, not this whole conjunctiva. You just put the conjunctival strip in the limbal area and then put an amniotic membrane over.
Mm.
Okay.
Oh,
But only this as a primary procedure, only amniotic membrane won't help that much. So you put a limbal,
thank you.
you put a conjunctival strip and then put an amniotic membrane.
I think all the talks, they were all amazing, and like from basics to the recent advances, all the 5 talks that were included in today's session, they were amazing.
Yes, ma'am. It was a beautifully curated session by the AIOS dignitaries. So with this, we have come to the conclusion of the session. I would like to thank all the speakers and panelists for joining us and giving their valuable time. And stay tuned for tomorrow's session, session 5 on cornea, tomorrow 10 a.m. Thank you, everyone. Thank you so much.
Thank you. Thank
Good night.
you, everyone. Good night. Thank you, Lippy.
Thank you.
Thank you.
Yeah, thank you, Lippy.
Thank you, ma'am.
You did a good job. Thank you, Lippy.
Thank you so much, ma'am.
Okay.
Thank you all.
Thank you all.
Thank you, sir. Good night, sir.